सोचना क्या, जो भी होगा देखा जाएगा। सोचना क्या, जो भी होगा देखा जाएगा। कल के लिए आज को न खोना, आज ये न कल आएगा। सोचना क्या, जो भी होगा देखा जाएगा। जो होना होगा होगा वही, सोच के तू क्या पाएगा। सोचना क्या, जो भी होगा देखा जाएगा। सोचना क्या, जो भी होगा देखा जाएगा। कल के लिए आज को न खोना, आज ही न कल आएगा।
This meeting is being recorded.
सोचना क्या, जो भी होगा देखा जाएगा। सोचना क्या, जो भी होगा देखा जाएगा। कल के लिए आज को न खोना, आज ये न कल आएगा। सोचना क्या।
দেবু দেবু
হ্যাঁ বলুন।
হ্যাঁ, এই গানটা একবার হলে বন্ধ করে দেবে, আবার কিছুক্ষণ
আচ্ছা।
করে চালাবে। হ্যাঁ, এই
ঠিক
গানটা
আছে, ঠিক আছে।
রিপিটেশন আর দেখে তাহলে বোর হয়ে যাবে সবাই।
ঠিক আছে, ঠিক আছে।
একটাই কি ফিল্ম আছে না আরো আছে?
না আরো আছে।
তো সেগুলো দেখাও পরপর।
হ্যাঁ করছি।
হ্যাঁ,
এই চুনাম
হ্যাঁ টাটা
পাঠিয়ে দিস।
আমার তো প্রেস রিলিজ হয়ে গেছে, জাস্ট আমি ছবিটা 4টের সময় আসবে পাঠিয়ে দেব। ঠিক আছে, ম্যামের একটা বাইক আছে তো আমার।
এই কে কথা বলছে?
ম্যাডাম ফ্রেমিংটা ঠিক আছে?
হ্যাঁ, সেটিং ঠিক আছে।
ফ্রেমিং দু সাইডে ওই যে স্পন্সর আর মাঝখানে যে
হ্যাঁ,
এটা হচ্ছে।
দেখেছি
আচ্ছা ঠিক আছে। ফ্রেমিং দু সাইডে ওই যে স্পন্সর আর মাঝখানে যে এটা হচ্ছে। ঠিক আছে।
जिंदगी एक सफर है सुहाना, यहाँ कल क्या हो किसने जाना। जिंदगी एक सफर है सुहाना, यहाँ कल क्या हो किसने जाना। हाँ, जिंदगी एक सफर है सुहाना, यहाँ कल क्या हो किसने जाना। अरे ओडले ओडले ओ, ओडले ओडले ओ, ओडले ओडले ओ, ओडले ओडले odle odle oh, odle odle oh, odle odle oh, odle odle oh.
नहीं 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 ये बातें है पुरानी। कैसी पहेली है ये, कैसी पहेली जिंदगानी। थामा हारों का इसको किसने, हाँ ये तो बहता पानी। कैसी पहेली है ये, कैसी पहेली जिंदगानी। ला 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 जू 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 जू।
একটু বেলার দিকে আসো।
আইরিন এসে গেছো?
হ্যাঁ হ্যাঁ অনেকক্ষণ। শুভজিৎ, শুভজিৎ, শুভজিৎ,
হ্যাঁ, বলো।
এই যে তোমার সুজয়ের ছবিটা প্রথম থেকে দিলে বেটার হয় না, স্টার্টিং এ? তারপরে তো এগুলো দিলে ভালো, মাঝখানে হঠাৎ করে একটা মাঝখানে আসছে।
না, ওটা লুপ হচ্ছে তো।
ও, ওকে।
ডক্টর অশ্বিনী,
ইউটিউবে অলরেডি লাইভ স্টার্ট হয়ে গেছে, এখন ওই যে যার মতো ফোনে কন্ট্যাক্ট করলে ভালো হয়,
ওকে
কারণ অলরেডি লাইভ চলছে, তো এই লাইভের মধ্যে এই অডিও গুলো ঢুকছে অলরেডি।
ওকে।
তো এবার যে যার মতো ফোনে কন্ট্যাক্ট।
Hello, Madhuparna. Good morning, good afternoon. Can you hear
Good afternoon.
everybody?
Good afternoon. Admin, can you please check the sound?
Admin, please check sound. Is it clear or needs to be something to be done?
Yeah, it is clear. It is clear. It's fine.
Yeah, panelists are requested kindly check your audios and videos, please.
Dr. Ashwini, am I audible?
Yes, ma'am.
Okay.
Very much audible.
And if someone wants to have a presentation, do we announce who will be doing this? Screen sharing rights will be given, right?
Yes. You can share your screen and
Sure.
show the presentation.
ठीक है, ठीक है.
Okay. Thanks.
Also, the Zoom link which is coming to us, it's going into the updates or the junk folder because it is thinking as a spam mail. So probably many speakers must not have got the link. It must have gone to the spam mail or something.
Hey, Prashant. Hey, Ashwini.
Dr. Alex, how are you, sir?
All well. How are you? Long time, Prashant.
Yeah, long time. You've forgotten about us in Calcutta, huh?
No. Very active. Your people are quite active. Soumitra, Rahul. So.
Yeah. And the team has picked up nicely. It's good to see.
Beg your pardon?
That team has picked up quite nicely.
Yeah. They've done. They're doing well. Both Anbai and HPI. They're doing quite well.
Right.
Yeah, I see Ashwini also here. Ashwini,
Alex sir, hi sir.
Hey. Good afternoon to you. So long.
Good afternoon, sir. How are you?
All well. We got this, Ashwini. Hope you're all taking care.
How is everything, sir?
All well. How is the COVID situation in Maharashtra?
That's slightly reduced.
Okay.
So last only 10, 12 days we were little okay.
Okay.
Because till the end of May and 15th of June till that it was little worrisome.
Good.
But now the Mumbai cases are at around 605, 550 or so.
We'll keep our fingers crossed and pray.
Dr. Alex, your sound is quite less actually.
Sir. It's difficult to hear, sir. Yeah.
Is this better?
No, same, no difference. Admin, can you please help Dr. Alex with the sound?
I'm just increasing on that. I think the volume has gone down. Yeah, is this better now? I've just increased it.
Yes.
Yeah, slightly. Yes.
Okay.
So little more if you can, little.
Max, this is a max on my computer. I put.
No, this will do, sir.
Okay. I'll try and talk loudly.
Better.
So even Calcutta, West Bengal, things are better, no, Prashant?
Yeah, I think so. West Bengal, we have a little bit of a tail end of the lockdown still remaining, as in the local trains, etc., has not started.
Okay.
My metro trains at limited capacity have started. The offices, etc., have started. But however, the local buses and local transport and transportation as in commuting via train and buses is problem area. Otherwise, the number of cases has sharply declined.
Oh, that's very good. Okay.
Yeah. However, we still require RT-PCR negative report from the boarding airport if anybody intends to enter Bengal.
Even if you're vaccinated?
Yes. Still now that remains.
Yeah, we are just giving a recommendation to the government of India, HPI and the airport, saying that if you're vaccinated, we don't need to do that, don't have to take temperatures. So let's see.
Right. As a matter of fact, we are now wanting only vaccine certificates at the tourist spots like Shanti, Darjeeling. But for entering the state, at the boarding airport, you still require. But here it is not a mandatory screen as such.
So let's hope we can change that and there'll be one rule for the whole country. That's one of the things we're trying to do.
That makes things much easier. Shubhajit, how's Richa? Is she?
Yeah, she's joining shortly. Mr. Sushil, you have joined? Mr. Sushil, you have joined?
Yes, I have joined.
Thank you, sir.
I'm just trying to figure it out. 1 minute. Please. Okay. Okay. Here I am.
Dr. Richa is joining shortly. Yeah, Dr. Richa joined.
Dr. Singh, all well at your side? Everything fine?
Absolutely fine. Absolutely fine. Mr. Nigam will be joining us by around 4:30. So we can start. Yeah.
Just another 2 minutes, we can start.
Sure.
Sure.
So, Dr. Singh, I just want to start with the 1 minute observership for Sujoy.
It's 4
in
o'clock.
his memory. And then
Absolutely, we should. Absolutely.
I really wish we could have done the physical format today. You know, it's been such a while.
That's true.
Yeah, we were hoping that government would relax the guidelines, but there is no clarity as such.
Especially after the Park Hotel incident, I think we are all even a little bit more, careful about.
Absolutely.
Good evening, everyone. I'm Upasna Arora.
Hey, Upasna ji, how are you?
Good
Kunal?
evening.
How are you?
Sonora, how are you?
Yeah.
I'm good. Good to
Kunal,
see
yeah, good to see you, Upasna ji. Kunal, how are you?
Hello, Alex. After a long time.
Yeah, it's a long.
Hello, Prashant.
Hi, Dr. Sarkar. How are you, sir?
Hi, everyone. Hi.
Yeah, hi, Vishy here. Hi, Prashant.
Hi, Vishy. How are you doing?
I'm good.
Dr. Kunal, I'm thoroughly enjoying your book. Your style of writing is absolutely so encouraging and entertaining at the same time.
Another feat of madness. Thanks, Prashant. Yeah.
After a few years, when we recollect the good things about COVID, so your book will be one of those things which will be counted amongst that list,
Yeah. This stops at the first wave. So the second part of the comedy is yet to come. So yeah.
So, should we start?
Yes, and then we can start whenever you're ready.
Madhupanna, let's start. Yeah. It's already 4 o'clock.
Sir, we would like to remember Shujoy, who has initiated this project. And I think we should observe 2 minutes of silence.
Yeah.
Can I have the photographs of Shujoy?
Yeah, Sudhito, please display the Sujoy's picture, please.
Madhupana, let us know when we go online also.
I would request Dr. Singh to say few words regarding Shujoy.
So basically, I'm sure everybody on this call, or most of us know Shujoy, but a very dear colleague, and we lost him to COVID. He struggled for almost more than 2 months, and we did everything to save him, but as it goes, we couldn't. So I think let's pray for the departed soul, and may God give him strength, and also to the family. So we can observe silence of a minute just to pay our tribute to Shujoy Ghosh. Thank you. Thank you, Madhuparna. Over to you. Let's start.
Thank you, sir. On behalf of Indian Chamber of Commerce, we welcome you all to this ICC National Healthcare Summit, which is one of our annual flagship healthcare initiatives. Today, we will discuss about the most prioritized topics of Indian healthcare at present. Our topics will comprises of future infrastructure of Indian public healthcare sector, challenges to build robust public healthcare system, challenges of private healthcare sector, healthcare investment and boost of Indian economy, healthcare insurance sector of India, ease of settlement, and future ready supply chain, innovation, market access, new trends in medical device sector. For our inaugural session, the theme is future infrastructure of Indian public healthcare sector. With these words, we are starting our inaugural session of the ICC National Healthcare Summit. I would request Mr. Prashant Sharma, Chairman, ICC National Healthcare Committee and Managing Director, Chanak Hospital, to kindly deliver the welcome address. Over to you, Mr.
Thank you, Madhuparna, and thank you, Dr. Singh, for bringing in the topic of Shujoy. Namaskar, everyone, and it is my pleasure to welcome you all at this August gathering once again. Shujoy was a very dear colleague, and we have done many events together, and I'm very glad that we started today by remembering somebody whom we lost to this massive pandemic, and I'm sure in all of our hearts he still resides, and may he rest in peace wherever he is. Today, I would like to initiate this program by extending a very warm welcome to all of you, all the respected dignitaries, all the attendees, all the officials who have gathered here today to join us in this ICC National Healthcare Summit 2021. I would like to extend a warm welcome to Mr. Narayan Nigam, though he's informed us that he will be a little bit late. It was under his very able guidance that, matter of fact, Bengal has done a very good job in terms of fighting this pandemic. I'm not saying it in a bureaucratic way. I sincerely feel it as a health administrator. The very quick steps, some missteps, but fast and quick action has enabled a lot of swift, decisive moves, which has enabled us to fight better. Many projects were given, and those are things which were just showing the morning of the day to come. I would also like to welcome Mr. Sushil Umesh, Chief Commercial Officer for Emerging Markets, including India, from the Biocon Group. We are all aware of the pivotal role played by the Biocon Group in our country. I would like to extend a very warm welcome to Dr. Praveen Chandra, the Chairman of Department of Interventional Cardiology from Vedanta. A very warm welcome, Dr. Chandra. This is our first event with you. We look forward to a great interaction with you, sir. A very special welcome to our very own Dr. Kunal Sarkar, Senior Vice Chairman and Senior Consultant of Cardiac Surgery in Medical Super Specialty Hospital. Dr. Sarkar recently unleashed his book, and I am one of the in the audience member. I'm thoroughly enjoying both the launch of the book as well as the book which is written covering the history, the present, and the future of healthcare. It is extremely enlightening. My recommendation to all attendees, please do buy this on Amazon, The Sickness of Health by Dr. Kunal Sarkar, and go through it for the information as well as the upliftment of our knowledge and entertainment as well. My very warm welcome to Dr. Alex Thomas, the founder and president of AHPI, role of which we at the health sector have been witnessing, whether it is advocacy in the center or fighting the case at the Supreme Court. Dr. Thomas, Dr. Gyani, and the entire team has been doing a fantastic job in this area. Last but not the least, my dear friend, Ms. Richa Singh Devgupta. She is the Senior Vice President of Fortis and also the co-chair of the National Healthcare Committee at ICC. Ladies and gentlemen, a very warm welcome to all of you. It is my belief that humans are at their best when they are undergoing adversity. Adversity brings out the very best of us. Whenever our back is to the wall, when we just bounce back and sometimes do the impossible. If a study is done comparing human performance during highly comfortable state versus that of when they are challenged, especially for survival, I think we can all guess what the outcome will be. This pandemic has once again put us in that position. While it has been devastating to the entire world, it has also taught us a lot many good things. It has made us do things purely out of necessity, which otherwise would have taken ages to do. Embracing digitization is one such thing. It has impacted many sectors, be it e-commerce or whatnot. But the way we have embraced digital healthcare and the speed at which we did it were both unprecedented. Even the most unsavvy users are now regular consumers of digitally delivered healthcare. This opens many new doors and many new avenues. As the saying goes, never waste a good crisis. I guess we can say that this is one such positive outcome from an adversity. There's a lot of data which shows that the per bed count of India, his per population, is much lesser. Data shows that India has about 1.4 beds per 1,000 people, 1 doctor per 1,500 people, 1.7 nurses per 1,000 people. Amongst these parameters, if we look at the doctor population ratio of few other nations, for example, for Australia, it's about 3.3 per 1,000. For Brazil, it's about 1.8 per 1,000. For Germany, it's above 4 per 1,000. Russia is about 3.3, and US is about 2.4 per 1,000. There's no doubt that this capacity of healthcare system has been tested and stretched to its limits in the pandemic. Even the shortages of hospital beds, oxygen concentrators, life-saving drugs, medical supplies, disease surveillance, etc., the health practitioner had to be given even more proactive role than ever, and the relentless effort over the past 1.5 years are not unknown to any of us. today at this ICC National Healthcare Summit, we would like to begin our conference by paying tribute to all those health workers, the COVID-19 warriors, who have laid down blood, sweat, and tears to service the patient population and mankind. Our tribute also goes to all the survivors who made it despite the odds, the martyrs whom we unfortunately lost despite the immense struggle, to one of the most unfortunate happenings of modern times. While COVID-19 has been an extremely unfortunate incident in the history of mankind, and no nation was prepared for such a devastation, India in particular, with a population of 1.4 billion and a population density of about 464 per square kilometer, bore the brunt significantly not just last year, but during the second wave of 2020 as well. While much talk had happened at the policy level about the need for better infrastructure in healthcare for quite some time, COVID-19 has surely shown the pitfalls, and it is time we all put in our efforts to strengthen this sector. If you look at the data a bit more further, it is revealed that in 2020-21, India spent about 1.8% of its GDP on the healthcare sector. The government of India considered health and well-being to be one of the 6 pillars of Union Budget 2021-22, and subsequently committed about 2.5 to 3% of GDP. However, despite efforts to increase government spending on healthcare, the most important pillar of the social sector, if we compare to other OECD countries' average of 7.6%, other BRIC countries' average of 3.6%, it is evident that India needs to do much more than what it is already doing. The silver line among all of this is that government has realized the exigencies and is working hard to contain further mishaps in the future. However, despite these efforts, we believe there is much more that needs to be done both from the urban and the rural healthcare sector in India. A densely populated nation such as ours should focus on improving healthcare facilities and increasing spending to a significant extent. Another area where the healthcare should focus in particular is integrating cutting-edge technology. We have the best of brains globally. Why not utilize it for the betterment of our own sector? It is time that India does not just remain the pharmacy of the world, but undertake effective measures in terms of infrastructure, technology integration, research, etc., to emerge as a prominent healthcare provider as well. With these thoughts, I once again welcome you to this ICC National Healthcare Summit and invite you to share your valuable ideas and inputs towards building a state-of-the-art healthcare infrastructure in our country. Thank you very much.
Thank you, sir. Now I would request Dr. Alexander Thomas, President AHPI, to please deliver the keynote address. Over to you, Dr. Thomas.
Please unmute.
Yeah, thank you for this opportunity. This prestigious Indian Chamber of Commerce National Healthcare Summit 2021. As we were talking, I think in the background of COVID, the pandemic has shown us the dark side of not having a decent health system. This catastrophe that our country has undergone, not only our country, but as Prashant said, we actually bore the brunt of this. This catastrophe has shown us that, and the world, the after effects, the effects have been horrendous. And I think all of us pray that we will not see something like this again in our lifetime or in the next generations. It has killed so many people, made martyrs of so many of our colleagues and patients. It has left so many of us in the population with scars. So many children have become orphans, lost both their parents. Many have lost their breadwinners. And I think it is not a well-known fact, but a recent study by the Tata Institute of Social Science has said that about 240 million Indians have gone into below poverty line from the middle class. And that, I think all of us need to realize, that is a living death. And this has really, really destroyed the fabric of our society, especially in our country. So today I won't talk about vaccines and some of the other measures. I think we'll keep it broad. Have we learnt any lessons from this? Sometimes I'm a little aghast when I go out into the road. Our public memory seems to be very short. But as a community, as a government, as healthcare leaders, I think we need to take some lessons from this. Has been a very grievous, a very hard-hitting lesson, and we need to take stock of the situation and see where we can improve. I think the biggest, the first point, I very broadly look at the big picture. I won't focus on too many things, but we have been saying this, and I hope the government listens this time. I think we need to ensure that the adequate budget is given to health. As was mentioned earlier, my personal feeling is that the last budget, which went up to 2 to 3%, was not actually an increase in health. If you actually look at it, a lot of other things were added. So it is our plea to the government to actually implement this in the true spirit. Increase the budgetary allocation. I think we all realize that one of the reasons this affected us in India so badly was because of the lack of our health resources. So I think the first and foremost, and HPI is pushing this, saying that please increase to at least 5%. I think that's the bare minimum where we would be able to build up our health systems to face any exigency like this. We have been pushing it, but I hope the government has woken up. Now, I think that if you look at the infrastructure in government, generally speaking, I think it is on an average, it is satisfactory, but yes, we need to improve our infrastructure. The most important area where we are facing a threat, where we are facing a shortage, is human resources in health. I think this is one area where the pandemic has brought out that if we do not wake up, we are going to be in trouble. We have been lobbying with the government, and I must say to the government's credit that number of MBBS seats have increased to almost double, number of PG seats have increased, but there is a long way to go. You heard the statistics of the ratio, and especially during the pandemic. So I think it's important that we focus on this. Doctors, nurses, other paramedical staff. I don't know whether you're aware, but the salary of a junior doctor has skyrocketed to about 1.5 lakhs. The salary of a nurse in the Middle East, the salary of a nurse in the UK has almost doubled. So there is going to be a brain drain. I don't believe in keeping our people back. I think they also have to look at their future. But I think this brings out a problem that in the next few years we are going to have a severe shortage of doctors and nurses. Many of them are going to go abroad. So I think it's very important that we continue medical reform at a very rapid pace. We need to increase the number of seats. We still have some archaic rules in the National Medical Council, where to start a medical college, you need an average of about 400 crores, which is absolutely not necessary in this time and age with technology. So we are pushing that any hospital which is about 300 beds be made a medical college center, and that the cost of medical education comes down significantly. We feel we have done a lot of research in other countries, and we feel that what is happening now is totally unnecessary. And in the country now, we need quality, affordable medical education. So that is something that we all need to focus on. Nursing, we need to ensure that our nurses are competent. A study done recently, at least in my state of Karnataka, showed that 50% of the nurses who qualify don't know how to hold a syringe. That's a very, very sad state of affairs. Reasons are many, corruption, etc. But I think we need to bring in nursing reforms. We need to ensure that we get more nurses. We need to ensure that our allied and supporting staff also, the numbers increase, quality increases. And I think, Devi and me work together a lot, and I think he's been saying this. India should be the reservoir of health talent for the entire world. And we, believe me, do it if we are able to tweak a few laws here and there. Because sometimes I feel very frustrated with what is happening. In this time of COVID, there was a shortage of doctors. It was the young doctors who were in the front line who worked and worked and worked. But you may not believe it. At that time, there were about 150,000 MBBS doctors sitting at home studying for exams. We won't go into the reasons, but here's a time crisis. There are doctors, we are not able to utilize them. Another area, I think all of you must have heard of the foreign medical graduates who go outside the country, study and come back. There are about 25 to 30,000 of them. Many of the other countries, these people are used as doctors. In our country, no, they have to sit for an exam. I agree, exam should be done. Only about 25% of them, not 25, 25 is the best of times, of them pass. So they're all getting frustrated. And recently, I think some laws have, new proposals have come where they are allowed to sit only for twice. They're allowed they are discriminated against by having another exam. So we are engaged with the National Medical Council, but I think the government needs to open its eyes. When there's an opportunity, let's use it. We have ready-made doctors with just a little bit of training, they will get into our system. So it is important that we encourage our youth, encourage them in large numbers to join the healthcare system, because healthcare is one area where it is recession-proof. You have your career growth. Unfortunately, the recent incidents of violence all over the country also discourage youngsters from joining, but this is one area where we actually need to look again and ensure that healthcare is something that would be a good career for youngsters to come in. The other area is that I think all of us, maybe about 4 or 5 decades ago, the MBBS doctor handled most of the ailments. He was a family friend, used to do small procedures. But today, because of various reasons, the courts, society, the MBBS doctor is not more than a clerk. And I think we need to introduce medical reforms where these people, the MBBS doctors, are the fulcrum. They become the family doctor. They handle the small things. This will also help reduce the stress on the healthcare system. And I think if you look at in our country itself, you look at the states which have done well in this, in staffing and infrastructure and giving more money to health. Look at Kerala, you look at Karnataka, you look at Tamil Nadu. They've done fairly well if you compare the response to COVID compared to the Bimaru state. So I think it is important that we focus on these areas. All of us know the adage that prevention is better than cure. We must compliment the government of India on this concept of these wellness clinics, 150,000 wellness clinics. Somehow it really hasn't taken off, and I think the next focus of the government should be to ensure that these 150,000 wellness clinics, the primary healthcare centers, are adequately staffed, they're adequately accountable, because these are the cornerstones of health in our country. And I think we need to ensure that through these centers, wellness centers, through the primary health centers, that we prevent disease like non-communicable diseases, diseases associated with climate change. And here again, this preventive aspect will reduce the disease burden and also reduce the stress on the tertiary care hospitals. As was mentioned earlier, I think there is no doubt that we need to use technology to make health accessible, to make health affordable. In fact, I'm reminded just before the lockdown in Karnataka, Devi and myself and a few others, we were part of a vision group. And we had given a strong recommendation that telemedicine be made legal. We've been fighting for that 3 years earlier. There was a big wall. And I said, there is a silver lining in every situation. And this in pandemic, I think one of the big things was that technology has now really been used, starting with the telemedicine laws. So it's not only technology making accessible, health accessible or making it more affordable. I think we also need to use technology to make the public health institutions accountable. We have a large number of public health institutions all over the country, right from the primary health center to the taluka hospitals to the district. And unfortunately, there is not much accountability. We have started something in Karnataka where each district hospital is supposed to send back its statistics and its outcomes. Technology makes this very, very easy. And we have examples of public health institutions doing excellently. We have the NIMHANS, we have the Jayadeva Institute, and I'm sure in other parts of the country we have. So there is no reason that any government or public health institution cannot become centers of excellence. Unfortunately, if you look at the situation today, probably just 1 or 2% of these institutions are doing as they should. And I think if you are able to set them right, a large number of the population will benefit from this. Telemedicine was already mentioned, and the technology, I think the vaccines is another example of where technology was used. It normally takes many years for a vaccine to be developed, but because of technology, we are able to get it in less than a year. I'm trying to focus on saying that we must use technology in every aspect of health that we practice in without compromising on quality. Very importantly, our country is a little backward in research. We have a huge amount of clinical data. So I think a combination of research and technology will augur well for our country in the years to come. And we will I think benefit immensely. Third point which I want to mention, which is something which is very important, we've only been talking about this. This is the public-private partnership. Fortunately or unfortunately, the private sector contributes almost 70% of healthcare in this country. And I personally feel this is not healthy. It should be 50-50. But anyway, as of now, it is about 70% to 30%. Unfortunately, though, we work with the government. My background is I come from a mission hospital. Dr. Gyani comes from the government. So we look at things differently. And over the last 6 years that I've been working with the HPI, I've realized the tremendous contribution that the private healthcare sector has made to healthcare in India. If it was not for the private sector, you can be sure that the state-of-the-art treatment which is available now at such costs, if you compare to what is abroad, would not have been possible. So this public-private partnership, I think, is very, very important. Unfortunately, most governments, including the central government, look at private healthcare providers with a very biased eye. I think they feel that the private health sector is out to make money. There's nothing wrong with making money as long as patients are not exploited and the needy are not turned away. So this is something that we need to work together. The government needs to realize that the private players are very, very important if we have to make any impact. And I'll give you an example that in Karnataka, we are very fortunate that we have worked with excellent bureaucrats. And over the last few years, we have worked with them to get accreditation for government hospitals. We recently got accreditation for NIMHANS. HPI helped them. We worked with the government to ensure that district hospitals get pediatric surgery facilities. And I think a very role model that I always like to talk about is that we have worked with the government to ensure that all district hospitals become training centers for national board. And this, they were just giving me feedback the other day. They said the residents in these district hospitals played a stellar role in fighting the COVID pandemic. So my moot point is that we have to work very, very closely with the government. Rather, the other way, the government has to work very, very closely with private players. And I think one of the aspects where we had a big difference of opinion is in the pricing. Now, if the healthcare of our country is to be of some level, the private hospitals, which provide 70% of healthcare, need to be financially viable. A few years ago, I was a member secretary, Government of Karnataka, where we did a study on the costing. And it was very, very clear that even CGHS is an insurance scheme. I'm not talking about the Prime Minister's Ayush scheme. That the CGHS rates, what the government was paying the private players was about 35 to 50% of actual cost. So in effect, every CGHS patient was being subsidized. So I think this is one area where we need to be very clear. We have actually engaged with the government. We had gone to the courts. The courts have said that you cannot do a pricing without costing. And we are now actually working with the Institute of Cost Accounting Delhi. It's an autonomous body. They have taken this up and we are part of it. The government is part of it. And we hope that working together, we will be able to come up with a scientific assessment of costs. And the private sector is not asking to pay the high prices. I think to keep us sustainable, to help us be part of the government schemes, I think it is important that the government is conscious of this. So I think this is very important. The private sector also needs to ensure that the trust between the patients and the hospital there has been a lack of trust in the recent past, and I think that is something that we need to get back. This is very, very crucial. So let me end with this saying that if we are able to provide, if the private, the government, we get together, we work together, if we are able to provide universal healthcare to our population, to every citizen of our country, wherever he is, I can assure you that in a matter of 4 to 5 years, India will be an economic power to actually, we will be probably one of the superpowers in the country. But I think it's not a very difficult journey to traverse, but I think we need to keep this in mind. A healthy nation will be a very a powerful and a prosperous nation. Thank you once again for giving me this opportunity.
Thank you, Dr. Thomas. So today's our chief guest, Mr. N.S. Nigam, he has already joined. So may I request Mr. Nigam to deliver the address?
So before Ms. Nigam sir comes online, let me just brief all the attendees here. Over the last 1.5 years, as providers and recipients, a lot of us have seen a lot of policies and actions which have actually taken place. We have at the helm of affairs seen Mr. Nigam being very hands-on, Mr. Nigam being the Principal Secretary of Health. The war room which was created, war room-like situation and decision-making which was created as Swasthya Bhavan government of West Bengal. It is fantastic. I mean, I come from private sector through and through. I have never seen government machinery working in this fashion. Decisions were made in split seconds. Multi-crore decisions were taken across the table. A lot of important super steps were done in record time. And I must congratulate the capable handling of the situation by the government of West Bengal under the leadership of Mr. Narayan Swarup Nigam. And thank you, sir, for making it all possible. And thank you and your entire team for coming on the war front with all of us with your sleeves rolled up and to hands-on lead and show the way. It has been a pleasure working with you and handling this battle. And I welcome you once again to our summit to kindly deliver on your note. Thank you, sir.
Kindly unmute. I think you're on mute. Yeah.
Thank you, Prashant, for all the good words that you have spoken. But it's a big teamwork which happens in any such crisis, and definitely the entire team has risen to the occasion. I'm not alone. I'm not the sole person who can take all the credit. There's a huge team of more than 1 lakh of maybe 2-3 lakh people of Bengal, both in the government and in the private sector, which were involved in this entire journey or entire crisis management. And let me tell you again, as a word of caution, the crisis is still not over. We have seen 2 worst waves. First wave was rather manageable. Second wave definitely was a much more than what we ever expected. We are looking forward for a cooperation with all of you for dealing with the third wave. With this COVID, the entire COVID scenario has brought again the healthcare in the prime focus. Not only in terms of hospital infrastructure, but the manpower, with the oxygen supplies, with the technologies, with the telemedicine, with preventive healthcare, with dealing with all the branches of health together. Everything, I will say that the healthcare pre-COVID and healthcare post-COVID are going to be different. Maybe in time, maybe it will evolve 2 to 3 years more when we will be evolving the complete new model in which the healthcare will be looked into in a holistic way. Everyone today talks about that India's per capita expenditure on healthcare is low. Our GDP to healthcare ratio are not favorable. Our state budget spending on healthcare is not favorable. I agree with most of these points because the evidences across the world says that as you grow, as your economy develops, as a nation develops, their involvement, their expenditure on the primary healthcare definitely goes up. Now, only allocation of budget is never sufficient. As in government, many a times we are afraid of taking more funds because the more fund involves more innovative ways of expenditure, finding the avenues of expenditure so that everything which is given to you is spent properly. So similarly, when you look at the private sector in a holistic terms, private sector will definitely, capital will never flow unless until your models are correct. And it definitely provides a better return to an investor to invest in the healthcare development. Now, if you have there is a set of people who can pay anything and then you can create an infrastructure for them. But when you talk about creation of infrastructure for the masses and the facilities which can be used by everyone, the cost becomes very effective. So the modeling of all these instruments are very primarily, it's of a great importance. When we were dealing with the COVID and the healthcare, initial phases, India has also evolved in its journey to the public health. When we got independent, country was 40 crore population. Today, this country, with all the whatever we discuss about, we support the 130 crore population. Generally, people are fed. Your immunization standards have gone up. Your maternity, IMR, MMR, what the doctors all talk about, the public health especially, all have improved. Your MMR has gone down. Your infant mortality rates have improved. Your malnourishment still remains a concern for us. So the country has made a journey from where we started and where we are. Definitely, country has made a journey. West Bengal has an extraordinary record in terms of improvement in our IMR and MMR and the immunization rates and all those things. And many diseases have been eradicated. Now we must not look back that nothing has been done in past. Just to give me a minute, please. Sorry for the interruption. There was an urgent call. Now, if you look at it, so now the new paradigm has come that we are moving ahead with the routine, the communicable diseases to the non-communicable diseases. Now, again this has brought back the subcenter. I will go with the lowest level, the subcenter level. There is a huge change now. We call it health and wellness centers. Basically, they are the kind of clinics at the lowest end for the providing the primary health care. Now, it is a place from where the basic structures will be structural changes, and we will be gradually growing up and improving the tertiary care. Now, as far as the West Bengal government is concerned, if I look at holistically, everywhere we are using two things. One is a very active participation from the private sector. Like if you look at we have a huge set of diagnostic centers which are running up. We spend more than 300 crore rupees for providing the dialysis facility, for the CT scan, for the MRI, for the PET scan and all whatnot across the state, and we are further expanding this. So this is all done through a private sector participation where the standardized rates, bidding processes, all of it has been done quite in a big way in last few years, and it has really established itself. This is one part of it where we have really brought the private sector in place. During COVID management also, we got into the assistance of the private sector. What we did that we have a scheduled rates, we discussed with them and came out with the scheduled rates, and then we requisition certain beds. In Calcutta, there was a demand, supply, mismatch and all those things. Some beds were taken, some beds were left. So a good model was developed in which both the persons who can pay are getting a facility and persons who are not in a position to pay, governments is coming forward and taking the lead. This is the second big thing that we have done. Last but not the least, we run the biggest healthcare assurance program in the country. Everyone in the state is covered. Every family in the state is covered with a 5 lakh assured cost of assured treatment, both in the government and the private sector. No money required. Now, more than 1,600 hospitals are involved in the process. They are empaneled. Some are offering specialized services, some are offering the routine services. But this has led us to add roughly 50,000 beds in the private sector especially in the places where remote districts, it is also driving lot of investments in the private sector. At the beginning, I was telling that healthcare, if you want to draw a private investment, then the modeling has to be such that it brings in not only the private sector efficiency, but that will only come if you can provide an assured return. So roughly whopping 2,500 to 3,000 crore worth of scheme that we run, in which what not we do. Even the cancer treatments are being done in a private sector under this program. Even the heart walls, small children heart walls, that the closure things and all those things, the critical surgeries are also being performed. Neurosurgeries are being performed. So we are also creating a big ecosystem so that no one remains unattended for the want of access to the healthcare. This is something which is going to be a very long-term perspective that we are developing. Coming with all the investment which the government is doing, so there definitely with the investment that flows in, if I look at the budget of the state government, recently government has given this year budget of whopping 16,000 crores. Now, if you want to spend this kind of budget for a healthcare, then you need to look at it in another holistic perspective, whether you are intelligent and smart enough to invest this money. It's not that your dressing sense improves, not. I'm talking something about whether the adequate layers of intelligence are inbuilt in the system. So we are now collaborating. We have got a National Digital Health Mission, which is coming in the country. We are also developing our integrated health management system, which will be not only coming, which will not be looking into only the government sector. It will also be catering and integrating with the private sector, where the health registries, the digital depositories, all those things will be taken care of. Even the referrals are moving across everywhere. So that is kind of an intelligence and the smartness that we intend to build into the system, so that you will also bring in the efficiency. Last night only I got a phone call around 12:30 from someone. My son needs a neurological treatment immediately. Where should I send it? The option is, see, this is also, you can take it as a demand. You can also take it as an opportunity. The system should be capable enough to locate where these beds are available, either in the government sector or in a private sector, coordinate and send him across. By the time the person comes, his report should also be reached. There should be an ambulance to take it forward. So all those things, if you really look at it, you need to build up the smartness in the system. And for that, you need to have a very big IT revolution as far as the healthcare management is concerned. Whatever we are looking at the healthcare today, it is happening in isolations. That one software we install there, another software we install there, but the labs don't speak to the hospitals and the hospitals don't speak to the referrals. So the things are not seamless. So that kind of seamless things have to be developed. Some systems have to be evolved. Some checks and balances have to be created, so that you bring in both the transparency as well as efficiency in the system. This is the second. Third, which I'm finding it is going to be a next big thing which will happen, will be a telemedicine services which are going to come. Not every person, I was talking to some of my doctors here, they were saying that, sir, you need not get every person to my hospital for a management of a brain stroke. You give me a hub and spoke model, they let the hospitals be there in periphery, 3 of my senior residents and 2 of my senior doctors will be there. Let the report come over net, and we will tell them that you start the treatment immediately, so that you don't lose on those critical hours. As of now, in case in Calcutta, when we find that if anything happens, say in the north of Calcutta happens, everyone lands up in medical college. If in the south of Calcutta anything happens, right from Sundar, everyone lands up in the PG hospital. So that's why the few institutions remains always crowded, and the few institutions per se remains vacant. Now, there may be variety of reasons for it, but at the end, you are not having the information what you need to do at that golden time. So we really need to look at both the telemedicine part of it, so that you can take care of it. Now, when we talk about health and wellness center in a very big way, what is happening that we are now developing, roughly we will be developing, rolling it over in next 2 years, minimum 15,000 centers across the state where the telemedicine services will be available. We have just tested our modules, and it will be big telemedicine setups. We have already had a hands-on experience of running a telemedicine setup during the pandemic. We were running around 120 doctors were serving the round the clock for telemedicine, both in terms of video telemedicine as well as the audio-based telemedicine. And we have seen that it has evoked a very big, huge response from everyone. So this is another part which is going to take care of it. Now, there's one more thing which the healthcare should plan for the future is about development of the next phase of the healthcare which is going to come up, which is both the mental health care as well as looking at the serious issues which country is going to face in times to come. As of now, we are all passing through the demographic dividend where the population is young, but you will also grow old in another 10 to 15 years, and then the old age population will also come up. As the old age population come up, whether you have a system of the geriatric care, whether people are trained there or not, whether your hospitals are friendly to old people, whether you know how to handle those care equipment, whether the caregivers that are available in the cities, are they certified? Do they know the basics of the care providing? All those things will also open a huge participation by the private sector, and this is also, I request that let these things be deliberated across different forums so that the requirement for these facilities do come. You believe that we must understand that the demographic transition from the young will happen to the old, and then whether your systems are strong enough to take care of old age ailments, your hospitals are equipped, whether the person, when today you are having a person above 80, are very few coming to the different hospital, but tomorrow it so happens with all parameters being improved, you may have people coming up to 100 years, and there will be 20 people lined up for 100 years. How will your OPDs will respond to it? Are we capable? Are we started planning for those cares or not? That is also something which is very essential. Last but not the least, till now the healthcare is always talked about in government generally by the management of communicable diseases and the reproductive and child health. In the private sector, it's all about the tertiary care. But what happens about the whole gamut of the preventive health care? So there will be more and more demands will be coming toward this side, and how well we respond to whether we have a sufficient number of Ayush facilities available. Everyone talks about Ayurveda, but suppose you want to go to specialized services, whether the e-services can be made available for this sector or not, whether there are sufficient number of training programs which are coming up, whether the occupational issues associated with the preventive health are being discussed in the private sector or in the offices, and all those things are also going to be of paramount importance. So my only is to express everyone that today the healthcare is at a very critical juncture, when you will be the way you were talking about climate change, the way we have discussed about the green power, same way time is going to come to talk about a new dimension of the healthcare, which will include the preventive healthcare, which will include the development of telemedicine services, which will include overall putting up a smartness in your healthcare, so that the things are well connected, well integrated, and at the end you meet up the common goal that everyone should be healthy and there should be a healthy nation overall. I was listening to the previous speaker. He has rightly pointed out. So this is something which we really need to look at. Thank you, Rajivji, for organizing this program, and it is an excellent opportunity to interact with you. My boss is about to come. You saw me to go out, so he's here. So I am taking a time off.
No, absolutely. We know that.
Share the findings of your deliberations with us, and we will take it forward. Thank you.
Absolutely. Thank you for being with us, and I think we truly enjoyed listening to you.
Thank you so much.
We know that you have a meeting.
Sharing your opinion. It was really valuable, sir. We look forward to working with you again.
Thanks a lot. Bye.
Thank you, sir. So now I would request Dr. Kunal Sarkar, Senior Vice Chairman and Senior Consultant Cardiac Surgeon, Medical Super Specialty Hospital, please address us on challenges to build robust public healthcare system. Over to you, Dr. Sarkar.
Thank you, madam. I hope I'm audible. Right. Thank you, Prashant. Thank you, Dr. Singh, Shubhajit. And honestly, at the beginning of it all, this afternoon, I remember my friend Shuja, because not only did I know him for quite a few years across all the programs that we've had in the public domain, but also I was a part of the fight that valiantly struggled to salvage him from the clasps of a rather merciless condition. I was waiting for the opportunity for the Health Secretary to sign off, because I have a great exception to one of the comments which repeatedly keeps on saying that India is a young nation. Because whenever a country whose birth rate has flattened for the last 15 years goes on claiming that we are a young nation, it is an axiomatic proof of the fact that how helpless and how useless your healthcare system is. Because all it means at the end of the day is that this healthcare system lacks the intelligentsia and the capability to keep the 60+ population alive. So I think, if you flip through the pages of my book, I will request people seriously and germanely ingrained in healthcare to refrain from making this advertisement repeatedly that we are a very young country, because this boomerangs on you. Because if you look at our birth rate and our death rate and our present demographics, it should worry anybody who thinks a little bit seriously about the healthcare situation. Look, Indian healthcare is something like a chronically malnourished 73-year-old man or woman, and you are trying to give him a lot of parenteral nutrition in pandemic times over the last 1.5 years, and making this chronically malnourished creature develop 6 abs system or look like Arnold Schwarzenegger in a matter of 6 to 8 months. And I don't think that nutritional exercise is very, very useful, because Amir Khan and Salman Khan has done it a few times. I don't think the healthcare system will be very capable of copying the Bollywood superstars, and looking thin or fat over matters of 3 months is a rather difficult task for us. Let us start with the question that what do we think? What does the country want to do? Does a country of 130 million people, which became independent after centuries of colonial depravity, after a traumatic birth process, does this country really want for an equitable and sensible distribution of healthcare across its 30 states and 1.3 billion people? And if the answer to that question is yes, then we have to weave the fabric on which this system can be based. And one of the main problems that I identify through my journey, through my treks in Indian healthcare, is that, like your first wave and second wave and impending third wave, the policy making in Indian healthcare has gone through a very simple harmonic swings of schizophrenia. We've had 5 years of very socialistic thinking, followed by 5 years middle of the road thinking, followed by the next 5 years when the policy swings towards a public-private partnership. Now, this kind of inconsistency of basic policy making, I think, is very difficult in a system which is 70% augmented by the private healthcare capital. It should not be a statistic of shame, as Alex said, as Mr. Nigam said, as everyone has said so far, that yes, today the private healthcare system in India accounts for 13 lakh out of the 20 lakh beds in this country. Today we account for a substantial chunk of both the IPD and the inpatient treatment. So, ladies and gentlemen, the question remains that why should we be treated like the prodigal son in the dinner table, where policies after policies are framed, where the private health system is not a part of it. Perhaps you did not want to follow Adolf Hitler in Germany during the Second World War, but do spare a thought and follow the practices of the German healthcare system today, because Germany regulates, controls, fixes the price of its entire healthcare system without owning a single hospital in the country. It is a not-for-profit, private trust-based healthcare system which is coordinated and synchronized by the government. It is 80% funded by the taxpayer system, and it is 20% supplemented from government insurance for those people who are unable to bear the tax of healthcare coverage themselves. So our ideas will have to evolve. In today's perspective, the truth probably lies somewhere in between the bipolarity of the American healthcare in one hand and the Scandinavian or the British healthcare on the other. So we have to find a path for yourself. We have to have a consistency of policy, which the investment, which the private sector, which the policymakers can identify and say, fair enough, this is the path we are taking, and hence this is going to be the plan for the next decade of Indian healthcare. There has been tremendous inconsistency in that. In November 2019, the Niti Aayog had a meeting, at the end of which the Niti Aayog came out and said, one of its key members, that the government healthcare is a sinking ship. I neither agree nor contribute to that comment. But soon after that, half of the 30 states went with their own sort of population healthcare insurance programs. And I think, the many of you who are invested in healthcare today would really be trying to guess that, what is the weather forecast looking like 6 months later from now? Where are the sentiments and where are the policies based on which, how much money do we need to execute Indian healthcare today? We need about 10 lakh crores in the system. How much money comes from the government kitty? About 2.5 lakh crore comes from the government kitty. 7.5 lakhs comes out of the public, out of the private healthcare, and out of the public contributions. Now, that being the case, it is a statistic of shame. All of you are aware of the fact that 7 to 10% of the lower middle class every year is pressed back into, is downgraded in their economic survival simply because of the pressures of that 60% of out-of-pocket expenditure. And in spite of Ayushman Bharat, in spite of Arogyashri, in spite of Swasthya, in spite of many other schemes across the Indian state, do we not ask ourselves the question that why are we not seeing a substantial decrease in the out-of-pocket payment? I think because 90% of the out-of-pocket payment does not go into hospitals, but goes into buying medicines, right? So we need a granular analysis. We need a compassionate analysis of where the money is following the resources and how the money is following the need to come to this question. I think Alex a little earlier mentioned about MBBS. Personally, I'm tremendously worried about the way exponentially we are producing more and more medical graduates. Because over the last 5 years, we have no evidence in front of us to suggest that the number of beds available in healthcare has not increased beyond 19 to 20 lakhs over the last 20 years. If 100 beds have been added, 110 beds have been lost. So what does it mean at the end of the day? You are producing more and more graduates. What are they going to do? But we are not expanding infrastructure in proportion. So do they become superfluous? And do we have cluttering of people, congesting? I give you an example of cardiology in India today. I think Praveen is going to speak next. He knows for the fact that today we have multiplied the number of cardiologists coming out of the system by a factor of 12. There are 12 times more cardiologists being produced, but the number of critical care units, the number of interventional beds remains static. I give you another example. COVID. During COVID times, there wasn't a single state in India which used up 50% of its critical care capacity. What does it mean? Were we keeping beds vacant? No, it doesn't. All it means that a lot of the critical care advertised capacity in various states and across the country appears to be fictitious. If you look at the Princeton database, West Bengal advertiser declares that we have 8,000 plus beds in the critical care. Even at the height of the second wave, I did not see the critical care bed count rise above 2,500. Why was it so? Why did we not deploy the rest 6,000 beds that were allegedly available? So we really need to cast a serious eye and do a practical accounting of what is the infrastructure and what is the manpower we are producing to man that infrastructure. A lot of things have already been enunciated in terms of, Prashant has spoken at length about the doctor-patient bed ratio and the rest of it. But I think today we require pragmatism more than the heady winds of nationalism. We need to be honest, we need to be clear, we need to be absolutely sort of intent on the fact that we will, in the next 10 years, there is no chance of India allocating more than 2% of GDP on healthcare. In the geopolitical context, no country which is surrounded by two arch enemies have ever contributed to more than 2% of healthcare ever in human history. It has not been possible. You will continue to have a disproportionate allocation to buy weapons, to buy Rafale aircrafts, and healthcare will continue to suffer. And if you want to prop up healthcare, you need supplemental enthusiastic participation of the private sector. And for the private sector to put its bid on the table, a private sector is looking for stability and consistency in policy making. A private sector cannot swing between socialism on Monday and capitalism on Saturday. That is what makes their life very, very, very difficult. Let us look at it in the eye. The last COVID package announced by the central government, 24,000 crores. How much was the healthcare, what is COVID? A healthcare crisis. How much of the emergency allocation out of the emergency COVID package was allocated to healthcare? 4%. So for a crisis which is riding on the back of healthcare, is 4% all the allocation we can make specifically for this sector? I am not, it is very easy to criticize the government. I'm just laying threadbare in front of everybody what are the compulsions of today's government. A country geopolitically keeping an eye on Pakistan on one side and China on the other, and a highly populist democracy on the other side, will forever be starved of proper input, financial inputs in healthcare. And in order to make that possible, as all of you have said, I wholeheartedly second the opinion, we must be trusting of the private sector. If the government is only a 30% fiscal partner in this exercise, if government was to sit in a boardroom, it would find very difficult to be the judge and jury of all healthcare policy when it continues to be just a 30% stakeholder in the entire process. This is a very baffling phenomenon in India today. So I would request bodies like the Indian Chamber to put forward cogently, in a well thought out kind of way, that you need to bring private sector not only in your capacity calculation, but also in your policy formulation. I think that's extremely, extremely important. Somebody mentioned CGHS. Look at the last costing committee meeting of the CGHS. To the best of my knowledge, when was the last time when the private sector was represented in the costing exercises of either Ayushman or CGHS or any other consider? I mean, that is honestly ridiculous. It is more ridiculous than ICMR being the COVID navigator of the country, being a research organization, when the Center for Disease Control is sitting back and sucking its thumb, right? So fair enough, but let the private sector, the private sector is very obedient. Fair enough, I give you full marks for obedience, but also let us learn to look after our own interests, to hold our heads high. We need to make a genuine appeal to the government that we need some kind of a navigational blueprint in front of us as to what direction Indian healthcare is supposed to take over the matter of the next sort of decade to come. Without which, I don't think we are going to get that extra 7.5 lakh crore, which is necessary to keep all the sort of the gears and systems of healthcare moving in this country, without which we will be looked upon as a burden, we will be looked upon as a curse of nature to the people and not a helping hand during their times of need. So I've just been a very sort of, stupid, honest technocrat into the system, but that is the way I have looked at it. And I just borrow one of the last lines from my book and say that I hope, I'm not entirely sure whether we evolve to being an economic superpower, that the rate at which the current account deficit, the petroleum prices, and the inflations are taking us. I hope that dream is true. But at least I think we can be rational enough and intelligent enough to say one day that healthcare in India works, not in spite of the government, but because of the government. Thank you.
Thank you, Dr. Sharkar, for your kind address. Now I would request Dr. Praveen Chandra, Chairman, Department of Intervention Cardiology, Medanta, the Medicity, to please address us on India needs cutting-edge technology to become global healthcare giant. Over to you, Dr. Chandra.
There may be some network issue. Maybe somebody can call him up. And
okay, Dr. Chandra, we can see him, but he's not speaking.
Maybe there is network issue, but or maybe in the meantime we can go to the next speaker.
Okay, sir.
And somebody can contact Dr.
Okay. So now I would request Dr. Richa Singh Devgupta, Senior Vice President, Fortis Hospital, also co-chair ICC National Healthcare Committee, to address us on modernized infrastructure, increased expenditure. Madam, over to you.
Good afternoon, everyone. First and foremost, thank you very much for having me here. I have been listening to all the distinguished speakers so far who have spoken, and a lot of good inputs, a lot of good thoughts have come out, right, which I much appreciate, and it makes my work easy, because when we talk about the expenditure, increasing expenditure, it does not say anything else, but obviously it states something which has been said multiple times, that if we compare ourselves to other countries, India particularly is spending much lesser on its GDP, as compared to any other country. It's a known fact. And I also do believe in that, see the gap that we have in terms of today when we are spending 1.6% of the GDP on the public health, and all put together, it comes to around 3.5% of our GDP when public and private spend is being put together. It is surely not sufficient, right? Because on an average, if you look at it for any industry where we have healthy healthcare infrastructure, the spend is around 7 to 8%. And then, of course, we have countries like US, which spends almost 16, 17%, right? It is I think, a debatable issue as to how much is sufficient, right? End of the day, I think what we are trying to target as the universal healthcare, where healthcare is available to everyone, right? It is something which is a goal to be achieved at. When we look at Indian healthcare expenditure, I think one key thing which we need to focus on is the penetration of insurance, right? Because as we all say that insurance is nothing but kind of in a way sharing the risk. And it covers the less fortunate people who probably may not, even if you talk about private insurance, may not have so much to pay for their premium. So if we can take advantage of our population, as it's a huge 130 crore that we're talking about, it would be in much better state. What is heartening in last few years that yes, insurance penetration has increased through these different health schemes which has been launched by the government. But I think what is crucial to look at it is that when we look at healthcare insurance person, there are three aspects to it. One is the beneficiary, which is the patient, service provider, right? And of course, the insurance company. So what's happening is companies, insurance coming in through the state government, the payout structure or even the coverage part of it is not sufficient. And that's where we say that 65 to 70% of secondary and tertiary healthcare is provided by the private player. While there is a participation from all the private healthcare player, but there is a bit of a reluctancy on two parts. One is the pricing point, and second, of course, becomes the payment which gets delayed. So that needs to be taken care. When I talk about the modernization of infrastructure, when I say it is not only the civil infrastructure that we are talking about, infrastructure is the complete ecosystem that we refer to, starting from manpower to technology to infra, the number of beds, number of doctors, everything. And if we look back within this last 1.5 years, that there has been so much of a change, and somebody rightly said that while it would take 1 or 2 years, but when we look back and we would see that how the healthcare has to be delivered, there would be a lot of learning which will be coming out through this COVID period, the way we have done. And as it is, like as we say that, when you're pushed to the wall, you do your best, right? So in spite of the second wave being so strong, so intense, and while in the process, unfortunately, so many lives were lost, but considering the infra that we talk about, and we all were knowing that where our healthcare system stands at a country level, I think we have done a fairly good job. And one good thing that has come out is the way government and private players have worked together during this time. And as Mr. Nigam said, that we cannot sit back and relax that, okay, we have sailed through wave 1 and wave 2. We definitely need to be keeping ourselves ready for wave 3, which people are predicting. And in my mind, as we look around and the number of cases that we are seeing in different countries, different cities where we have our presence, the numbers are going to come back, right? The only intent is that if intensity could be lesser, if we could be much better prepared, and we can deal with the situation in a much better manner. Now, talking about what is that we need to change. So first and foremost, I would say is that we need to be more open to the technology adaptation in healthcare. When we talk about technology, it covers both aspects, medical as well as information technology. Medical, yes, healthcare, and particularly if I talk about the private healthcare, I think we have been upgrading, and we have been adding and bringing in all that is required to provide a good high-level treatment. But when we look at the information technology, we have been very, very slow as an industry, I would say, in adaptation of information technology. But thanks to COVID, as they say that, everything has it's a good part of it, however bad or ugly it would be. So COVID has pushed us towards using the information technology in the best manner possible. So one of the outcome, as we said, and somebody did make a mention, I think it was Dr. Thomas who said that while we were struggling for last few years to get telemedicine across, to get the regulatory things in place for telemedicine to be taken as one of the approved tool by the government, that has happened in within a probably 30 days time as the pandemic started. And for all of us, it is something to see that how smoothly the adaptation of telemedicine has happened. So we need to further cash on it, because I think when we look at the larger problem of Indian healthcare, accessibility, it has been one major issue. And we sitting in East particularly, we can't ignore the Seven Sister is of Northeast. It can be easily reached out. Now what I have seen since the time we are offering teleconsultant Fortis, I have seen people from Chennai actually consulting doctor in Calcutta, whereas it was always reverse. We know that, those who live in Calcutta. And certain places I have seen that, doctors in Delhi being consulted by patients from Mumbai, because now it is more about the patient convenience, that which doctor is available to see me, because physically anyways, I'm not going to go to them. As long as advice is coming from any part of the country, it is good for me, right? So that technology can broadly help us fill the gap of accessibility in many parts of the country, even for tier 3 cities where doctors always have reluctance to go to on a regular basis. Second thing which I'm very, very passionate about is the nursing reform. When we look at our nursing, and Dr. Kunal Sarkar was saying that while the number of clinical talent has increased in terms of the doctors, but if you look at the nurses, many of the people who run nursing colleges, they would vouch for it, that a lot of seats go empty because nurses are really not opting for it. There's no clear-cut growth path for the nurses as to once they work for 8 years, 10 years, 12 years, where do they go, except in case if they're lucky enough to go abroad and probably fetch better money, right? But the portfolio, the work-wise, it remains pretty much the same. However, if you look in the Western countries, these nurses, a nurse who's trained in anesthesia actually can help anesthetize a patient, whereas for us, government would not allow it, right? It has also to do with their education. So the regulatory changes have to come in terms of the way nursing colleges are being today run, and also the quality of education that we provide to our nurses. And one thing also which we need to take care of is their remuneration, their salary, their take home. Only if you find it attractive, you would opt for it. So nursing is another thing which I would say for sure. Third thing, while we are talking about the modernization of infrastructure, I would say in our tier 3 cities, for sure, I think even the basic infrastructure is something which first needs to be put in place. I can tell you from my own personal experience that during COVID, especially the second wave, when we were struggling for the bed, I don't know how many times we would have felt guilty for not being able to provide a bed to the patient who landed it in your emergency. And it was even worse when a lot of patients from the peripheral areas, right, coming into the city in search of critical care bed, and they kind of going round and round and from one hospital to another. So if I think having good critical care units, critical care beds being available in tier 3 city is something which is basic, because it doesn't say that the people can become critical only in the urban cities. So that's another thing which I would like to highlight on. Fourth thing, somewhere to compensate, or as they say, cross subsidy wise, while I understand that our affordability is a concern, and hence India and even the private healthcare sector offers the services at a much cheaper rate as compared to any other country. But with that said, if we have more and more medical tourism happening, wherein people do prefer coming to India, if that's one sector which obviously is currently not working because of the travel restrictions and all that, that's one part where we really need to focus on, work on alongside the government, because government support is required to make it more patient savvy, those who want to come for medical tourism to our country. So these are some of the thoughts which I would like to kind of leave you with. And in interest of the time, and I would stop here and over to Dr. Praveen.
Hello.
Thank you, madam. So now I would request Dr. Praveen Chandra, Chairman, Department of Intervention Cardiology, Medanta, the MedCity. Please address us on India needs cutting-edge technology to become global healthcare giant. Over to you, Dr. Praveen Chandra.
Thank you very much, and it's a pleasure to share some of the thoughts on this forum. And today I'm going to, what has happened? Suddenly can somebody unshare? Okay. Okay. Is it okay now? Can you see my slides?
Yes, we can, please.
Okay, fine. So what I'm going to discuss today is that, we have reached some place in terms of healthcare delivery in India, and technology is a major role player in providing the best of care to our patients. So as you know already today, what has happened is in the last 30 years, people have not to travel outside of India. This is something phenomenal, because 30 years back, I remember people had to go to US or UK for a bypass surgery or angioplasty, and sometimes even cancer treatment. But today, I think 99.9% nobody has to travel outside of India to get this treatment done. So how has it happened? It didn't happen by chance. It happened gradually when the healthcare got trained, the healthcare infrastructure got established to a reasonable extent, and technology came into India. So there were many people who played this role in getting all this over, and really we have reached this wonderful point, but we have to go very far. Today we get patients from outside of India as healthcare treatment option destination, because the treatment here overall becomes cheaper and is of good quality. But we need to go further. And as you already know, as far as the heart disease is concerned, now coming to the heart disease, ischemic heart disease is the major killer, #1 killer of mankind in the world and in India both, as you can see from this chart. So it has all surpassed tuberculosis, encephalopathy, COPD, lung disease, etc., and diarrheal diseases. So we have to take care of heart problems, heart ailments in India also. Earlier, we thought that it is not a problem of India, but now, because of diabetes becoming the major scourge, we have ischemic heart disease, which is the commonest cause of disease burden in India. And we have an aging population, and this population is increasingly become more aged, as you are seeing. So we have to take care of these people who are developing heart problems. So in the last so many years, we started with coronary care units, cardiac care units, but now we gradually moved on to doing angioplasties, stent implantations, and bypass surgeries for the last so many years. But we have to move further, and we have to make treatment as simple, as easy, and as effective as possible. So we have moved from bypass surgery, which is very, very extensive, but very, very effective treatment, to more patient-friendly options like angioplasty, like stent implantation, and percutaneous valve implantation techniques. So the key driver of all this is the patient. The patient needs these treatments, and the patient profile is changing. And as I already told you, heart disease is becoming so common, so rampant, and so horrible and gruesome that it kills people. So we need to have upgradation of our technologies
new products have to come to India. And if we don't do that, we cannot become a tourist hub or a medical treatment hub, or we cannot make our population healthy so that they become productive, they are back to normal activities. So now coming to my specialty of heart disease. So what I can tell you is that because of the help of technology, we have moved further from the heart. Now we have started treating the arteries which are supplying blood to the brain, which are supplying blood to the legs, arms, into the abdomen, everywhere, wherever there is a heart and the blood vessel, we are able to treat that without doing surgery many times. Okay. And also the valves of the heart, I will show you, the valves of the heart also can be treated now without doing any surgery with the help of cutting edge technology. And one of the cutting edge technologies which has recently, landed in our hands, and we have started using it in very sick patients. In those patients where we used to say that nothing can be done, it's just counting hours, etc. And we don't have treatment options. Now we have treatment options, especially in a patient who has a heart attack and becomes very sick. So we can put a pump, and here you can see it looks like a science fiction, but it is real. And in these patients, we can put a small pump inside the heart. The heart has started becoming weak. It cannot pump enough blood and cannot undergo treatment like angioplasty or bypass surgery. In these patients, we put this pump, small pump, which is known as the Impella pump. And this starts, it's like a submersible pump, which we use in the water treatment, these tanks, etc. And here we can put this small catheter, which pumps out the blood from the heart and sends it in the entire body, so we can do the treatment. So these kind of technologies are really helping very sick patients. So here, but all this is only possible if we have a good ecosystem. Ecosystem means the government is cognizant, the insurance companies know what exactly we are doing, the academic institutes, the hospitals are able to use this technology and get this technology. Then, of course, patients who are really needing this should know that yes, this treatment option is available and they can get it done. So all this, if it acts in coordination, we can help patients getting the best treatment done. And as you can see here, we used to cut the chest. You can see the chest. All this is now old. We don't need to do all that. We can do all this through robotics. We can do all this through hybrid treatment options. And here you can see, this is a modern day operation theater where everything is done through a robotic arms. Person is sitting on the console and the robotic arms are actually doing it. So the preciseness, so the accuracy or going deeper inside the body is possible when we use these new technologies. You can see, we can just do a small hole inside the chest to do a big surgery, because we can put stents in those positions where we cannot. We can do these small, tiny surgeries and patients can go home in 2 days. You can see, this is a patient who had multiple blockages and he undergoes a surgery with just these keyholes. So the technology has helped us doing all this and making the patients better. And the benefits of these integrated options have really come into the patients only because of the coordinated activities of industry, of the doctors, the trained people, the personnel, and the healthcare facilities, which can really support these treatment options. So for the coronary arteries, now we have dissolvable stents, the stents which can dissolve inside the body. And in India also, we have made such stents with us where the blockage is treated. It is like a tablet. The person has a blockage in the heart. You get the stent done. The stent is treating the artery and then dissolves like a tablet. So nothing stays inside the body. So this is the advantage. And also we can many times make decisions much clearer so that there is no confusion. And these are the kind of technologies like intravascular ultrasound, where we can actually go inside the heart arteries. You can see this is a artery which is just 2.5 millimeters, and we can go deep inside and make these pictures. These are real. I can tell you, these are real pictures. These are not science fiction. And we have done all this. We are doing every day these things, but all this is only possible if you have access to all this. And How many people will have it? This is what we have to decide, that how we can make it cheaper, easier, better, so that we can do good these kind of treatment options, which are very, very effective and able to save lives, save heart attacks. We can even find out those people who are going to have a heart attack in the future. Now we can find out how. This is the CT scan, which can rebuild the heart outside, even without opening it, knowing whether the blockage is going to happen or not, whether there is a chance of having a heart attack or not. You can see these pictures. They just help us knowing whether this patient is going to benefit from angioplasty or a bypass surgery or not. So earlier, people used to open the chest and find out whether a surgery can be done or not. So you can see these are the labs where patient is just watching and the heart treatment is going on without doing any anesthesia. So it's all being done without anesthesia. Very, very sick patients are being treated today for the valve problems. And as you will see here, in this patient, the patient had a valve problem and the only treatment option was replacing the valve. But the surgery was not possible. So how do we do it? Now we can do it through remote control, doing these catheters, where these catheters can position the valve inside the diseased valve, and we can change it while the patient is absolutely conscious. So this is, for me, 20 years back, it was fiction, but today it is a reality, because technology is something which is changing the entire way, the landscape of medical treatment. And these are various kind of valves which are being made today. And we are very happy that these technologies are really helping many, many sick patients. These are the patients, you can see, they would never get a surgery done because of their situation, their disease. And today they are happy, watching their telephones after the surgery is being done. Elderly patients being treated. So all this is possible only if you have these technologies. And here another, you can see that there's a remote technology where we can, repair the valves of the heart without doing any surgery. Again, this is all possible by the help of technology, which is coming to us on a regular basis, and we are able to treat these patients. So these are kind of various examples where we can treat the holes of the heart. We can, this is an ECMO where the patient is collapsing. We can make the patient heart pumping inside the, the blood can keep circulating through the brain, even if his heart stops and oxygenation happens. So this is, and then once the patient improves, he can come back to his normal heart and lung function. So this is known as ECMO therapy. Then pacemaking therapy has become very, very effective. Holes of the heart can be treated by, these small little devices, and we can really prevent stroke today. The most devastating disease for any family or person is development of paralytic stroke. And today we can prevent it if we treat in time by these technologies, and treating the leg arteries, the kidney arteries, the brain arteries, everything, the entire body today can be treated by these interventional techniques. But we have to keep updated to improve our toolkit, to strengthen our armamentarium to treat these patients. So with this, I think, I'll stop here, and this is my, colleagues, and so expertise, the human touch is very, very important with the technology to deliver care to our patients and to get the best outcomes. Thank you very much. So if there is any question or any comment, please go ahead. I can't hear anybody.
Thank you, sir. Now I would request Mr. Sushil Umesh, Chief Commercial Officer for Emerging Markets, Biocon Group, to address us on stable pricing policy and lack of capabilities in innovation space.
Thank you, Madhuparnaji. I'm just sharing a slide deck. Kindly confirm if you can see it.
Yes, we can.
Yes, we can.
Thank you very much. First of all, good evening to everybody. And thank you very much to the esteemed speakers and to I learned a lot listening to all of you all, and thanks to the ICC for giving me this opportunity to speak to you. The topic that I'm going to talk is the stable pricing policy and innovation. I wouldn't like to define it as lack of capabilities or whatever of that sort. And now I worked for more than 30 years in the pharma industry, and I was fortunate enough that I have an opportunity to work in LMIC countries in sub-Saharan Africa, living and working there. I also had a chance to work in Europe with the advanced countries, and of course, a long time in India. There are some good things in our country, a lot of good things in our country. And there are some things that can do with a little bit of change, a little bit of improvement. And those two things, perhaps one of those two things is a stable pricing policy, which I think Dr. Sarkar has very clearly also pointed out in his talk. And how could we actually stimulate the innovation space? Very quickly, just to ground all of us, and I'm sure you're aware of it, we have the National Pharmaceutical Pricing Authority called the NPPA, which was set up in 1997. And the role was to ensure and enforce the provisions of the Drug Price Control Order. Today, the DPCO lists about 851 drug formulations whose prices can be capped. And the ceiling price is calculated from the AIOCD data, in which the formulation with more than 1% market share is taken, and the average price of all these brands selling become the ceiling price. Now, the rationale here is if you make the drugs cheaper, it becomes more accessible. And as the drugs become more accessible, it reduces the out-of-pocket expenditure on healthcare. There are various changes, various rules that have come in at different points of time. One of the things that I would like to talk about is, of course, it goes without saying that if the drug is affordable, accessibility goes up. But accessibility is also linked to many other things. Drug pricing is a part of the accessibility problem. If you look at the different therapy areas, based on the different therapy areas, the cost that the patient bears is different, whether he's a diabetic patient or a cancer patient or a cardiac patient. And the cost largely can be put into buckets. For example, the education awareness cost of making the patient aware, and then you have the cost of diagnosis, and then you have the consulting cost, and you have the hospitalization cost, and you have the drug costs. So drug costs, depending on the therapy area, the percentage of drug costs keeps changing. And I'm not getting into that kind of discussion. But if you look at the drug costs, the question to be asked is only pricing or making the drug cheaper going to improve accessibility? Because there could be some adverse impacts as well. Over the years, I know that the pharma industry has played a tremendous role in certain areas like education, in certain areas like awareness, and also in many areas of making the drugs available to far-flung terrains. In the past, in the pharma industry, we used to do things like the jeep tours or the taxi tours, in which the stockist and the pharmaceutical rep would travel with stocks to remote areas and make the drug available there and also train the doctors at that particular point. Now, there are two problems. If the drug becomes so low cost that the margins are not enough, why would the pharma industry spend time and the supply chain costs in making these drugs available? The second is there could be new cutting edge drugs outside, and scared of the pricing policies would not come into the country. And hence it's a double-edged weapon. So it's not always true that reducing the cost of the drug would make it more accessible, especially in remote territories. Now, I think this was already discussed. Anybody who is working, in the past many years ago, we used to work on a 10-year plan. Today, we are working on a three-year plan. Now, it is important to get predictability because the pricing suddenly changes. All the assumptions taken for business falls to the cracks. And hence, you cannot really work towards taking evidence-based decision-making to synergize business stability and sustainability. The third point is equal responsibility. While the price of a formulation is pulled down, for example, in this COVID period, we are all aware how the demand for remdesivir went up. It shot to the ceilings. And we had regular meetings with the DOP to ensure that this production is ramped up. At the same time, the cost of the raw material went up significantly. Now, while we brought the price of remdesivir came down, the price of the APIs or the active pharmaceutical industry ingredients actually went up significantly. There were intermediates that went up. There was a rubber bung that went up, the vials that went up. So there's an equal responsibility of the price controls on all the aspects, right from the APIs to the finished goods. Needless to say, if you have stable pricing, in terms of predictable stable pricing, you can invest significantly back into innovation. And hence I would say that innovation and stable pricing policy, they both go hand in hand. And if we need the pharmaceutical industry to be encouraged to invest in R&D, one of the things very important is a stable pricing policy. In healthcare, there are many aspects that we spoke about. A lot of speakers already have spoken about it. So I will not sort of dwell on those. But there's healthcare access. And we spoke about, Dr. Thomas in his talk very clearly mentioned about the lack of trained healthcare workforce, especially in manning the PHCs, district hospitals, and different places. We spoke about, in Mr. Prashant Sharma's talk, about the ratio of the nursing staff to what is required, etc. So that is one area which we definitely need to work towards. There are certain barriers to innovation, and I come from Biocon Biologics, in which we believe in innovations, not just incremental innovation.
Sir, can I interrupt you for a moment?
Yes,
can
please.
you please make it a full screen? It has been minimized, so
I'm sorry.
make it a full screen.
You can see it?
Yeah, this time.
I'm sorry about that. So,
thank you, sir. You continue.
Clear?
Yes, sir, it's clear.
Thank you. So there are barriers to innovation, and Biocon has always been an innovative organization, not just incremental innovations, but breakthrough innovations as well. We need there is lack of incentives for R&D. In terms of the patent regime, India is ranked 40th out of 53 countries in 2020. One thing is good, is we are within the top 50 countries. There is also a longer timeline for regulatory approvals, and there are some areas that we can work towards. The potential for growth is immense. We don't want to be just the pharmacy of the world, but we want to create a difference. We want to talk about affordable innovation that will change the life of patients, not only in India, but in different parts of the world. Increasing government focus, very clearly, we have seen the GERD has gone up in just 10 years from 39,000 crores to more than 100,000 crores. And that's a very good sign. There are many initiatives that the government is doing, like Agni, Startup India, etc., to build a conducive ecosystem for science and technology. These are good things that are happening in the world today. There are some things that can go faster, especially for a company like ours, where top line we are at about 7,300 crores. We have 13,500 employees. And I was talking to you about the innovations that we are doing. We have got almost 1,230 plus patents that we hold. Now, two of our novel biologics, and I must make a mention here because there was a lot of talk about COVID. One of those products is itolizumab, which is called Aljumab. And this is a product which has actually come from the lab to the markets. This is a made in India product. And during this COVID time, we managed to reach out to almost 27,000 patients with our product Aljumab. And I'm happy to say the response for this was extremely good. So this gives us a lot of pride. And this is an indigenously made MAB, and it has saved so many lives in India. We are now in more than 120 countries where our products are available. One more novel biologics that we've taken from the lab to the market is a product called nimotuzumab, which is Biomab for head and neck cancer. And even that is doing extremely well. So we can actually create these brands which can make a tremendous impact not only in India and different parts of the world. But there are some areas that we can definitely do better. And I have put these areas for innovation into 3 boxes. One is I call the accelerate piece. What can we do more and faster and quicker? There are policies, but what we can do to make it quicker. Basically talking about shorter approval timelines and regulatory pathways. And there are so many rules and regulations. Can we streamline the regulations of reforms from research, lab, to the actual final output in the market through a single window that will sort of encourage innovation? Can we have stronger IPR to protect MSMEs and startups? And these are important regulatory reforms that will encourage innovation, because I believe that we have got all the capability, we have got all the brain power. The thing is just to get them all together. The second box is incentivize. Funding reforms. We are not talking about PLI-linked incentive schemes, but can it be for a longer period of time? Because very often when we talk about complex molecules like a biotech, it has got a longer period for lab to market. And sometimes 5 years would be too less. Can we have newer creative financing mechanisms? And so that it is not only the company that takes the risk, because innovation is a risky business. So there should be risk sharing schemes between both the public and private sectors, and especially in areas that can be sort of taken up as challenge areas for the country. Can we talk about tax deductions that cover all expenditure pertaining to the lab to market journey? The third piece is, of course, collaboration with the academia and the industry linkages. Can we have mechanisms to link academic research with industry priorities? Can we expand the financing options within the academic bodies? For example, IIT Delhi's Global Alumni Endowment Fund. Can we fix and allocate a percentage of the proposed 50,000 crores for the National Research Foundation to support university industry joint research programs? And last but not the least, we have got to work and encourage the industry partnership with various sniper institutes. I think these are some simple things that we can work together. We can have a stable pricing policy, fund innovation, and make a big difference in the world health. And India can play a leadership role in this particular area. I stop here and hand it back to Madhurima ji. Thank you very much.
Thank you, Mr. Sushil Umesh. Now, I would request our Director General, Dr. Rajiv Singh, to kindly deliver the vote of thanks.
Thank you. And I must express my heartfelt thanks to all our speakers. I would say one of the most engaging session I have ever seen on healthcare. I think we heard some very, very interesting insights, right from the role of private sector, contribution it makes, technology, what we really need to address in terms of policy framework. How do we look at some of the learnings and put them to use going ahead? And also at the same time, the challenges. So I think personally for me, it has been really very, very interesting. And I'm sure the participants and the larger audience, which will view this on various social media platforms also will greatly benefit. Let me start by thanking our esteemed speakers. I think right from the Secretary, Department of Health, Government of West Bengal for updating us what Bengal is doing and some of his thoughts how the healthcare sector can move ahead. We are extremely thankful to Dr. Alexander Thomas for taking up some of the key issues in terms of the regulatory framework and making special reference to the human resource. A very interesting and enlightening address from Dr. Kunal Sarkar, who spoke his mind and really highlighted the role private sector is playing. Our heartfelt thanks to Dr. Praveen Chandra for taking us through some of the technologies which are transforming healthcare in India, and definitely Medicity is leading the way. I would also like to thank Mr. Sushil Umesh for taking us through the pricing policy, and also need to develop Indian brands and for the Indian drugs to also get their own space in the healthcare market. Let me also formally thank our chair and co-chair for making some very useful and insightful remarks. Mr. Sharma, thank you. And let me also thank Dr. Richa Singh Devgupta. I would also like to thank all our partners, sponsors who have supported us. And I'm sure the agenda which will come out of this will be shared with the relevant authorities. And as ICC Healthcare Committee, we look forward to having a follow-up plan for all the thoughts and all the ideas. Thank you so much.
Thank you, sir. So I would like to thank everybody for joining this inaugural session of the National Healthcare Summit. Now we are going to the next session, plenary session 1, 2, and 3. So I would request my colleague Irene Sarkar to start the session and inviting the moderator and also other panelists for the plenary session 1. Over to you, Irene.
Thank you, ma'am. A very good evening to all the dignitaries and the participants. We are now about to start the plenary session 1. The discussion will be on challenges of private healthcare sector. I would like to invite Dr. Richa Singh Devgupta, Senior Vice President, Fortis Hospital, Co-Chair, ICC National Healthcare Committee, Mr. Prashant Sharma, MD, Chanak Hospital, Kolkata, Dr. Ramakant Deshpande, Executive Chairman, Asian Cancer Institute, Mumbai, Dr. Ashwini Jogare, MS Nanavati Max Super Speciality Hospital, Mumbai, Dr. Kaushik Murli, President, Medical Administration, Quality and Education, Shankara Eye Foundation, Dr. Shubhrajyoti Bhaumik, Clinical Director, Peerless Hospital, Kolkata, Ms. Suparna Sengupta, CEO, Narayan Memorial Hospital, Kolkata, Dr. Gitika Madan Patel, MD and Trustee, Parul Sevashram Hospital, Vadodara, and Ms. Upasna Arora, Director, Yashoda Super Speciality Hospital, Ghaziabad. I would like to request Dr. Richa Singh Devgupta, who is also moderating the session, to please take the session forward. Over to you, ma'am.
Thank you so much. So I formally welcome all the panelists, and I think we are going to deliberate for next 1 hour on a very, very important topic, which I'm sure would be a large interest to the audience, is challenging of healthcare delivery in India faced by the hospitals in India. And as the introduction happened, everyone would have noticed that we have got some of the most capable administrators across the country on this panel. So I would like to take advantage of that situation. So while we go around the table, and rather go around the screen for all the visible panelists here, what we would like to do is that I would go in the order where the names are given, and I would like you all to pick up one particular challenge, not only elaborating on what the challenge is all about, but also give some insight that in your experience, how are you fending that what are the solutions that you have been able to devise when you deliver healthcare services at your respective hospitals. I think it would be insightful for all our audience, and I'm sure we would get to learn newer things from each other. So starting with my dear friend Prashant. So Prashant, if you could share what are the challenges that you have faced, particularly if you can elaborate more on one aspect and also share your experience in dealing with it and the solution that you have found for it.
Right. Thanks, Richa, and very nice to share though a digital stage with you. Nice to meet you once again. And my greetings and namaskar to all the co-panelists. A special namaskar to Dr. Deshpande, because he's right now sitting in Bombay and he's treating one of our family members. So very nice to have you here, sir. So Risha, I'm very happy that you took this model of one specific challenge, because that is exactly what I was about to also ponder upon. There are many issues which healthcare is facing, HR, finance, or regulatory, or X, or Y, or Z. And I'm sure each of us have our own favorites. However, I'm going to talk about one issue which is not a business issue, it's more of a social or a cultural issue. And that is the issue of this trust deficit, or this expectation from the hospital, or a commercial understanding of a hospital, or rather speaking more simply, the discount aspect of healthcare. Now, I was under the impression that probably it is only in a few places in the country, but it so exists that from north to south and east to west, this common problem, along with other common problems, are existing in multiple areas. What do we mean by that? For those not from healthcare amongst our audience, is that whenever a patient gets admitted in a hospital, they expect a certain discount from the hospital, and they use all tools and tackles and political and bureaucratic support to obtain that discount. Now, the same customer, mind you, when they go to any other consumer service, be it a restaurant or be it any other consumer service, they're absolutely fine paying the listed rates, but somehow hospital is equal to discount is ingrained in the back of our mind somewhere down the line. So I was sort of wondering why this is so. You see, it is a common belief in our country that, and this is there from the highest to the lowest strata, that hospitals overcharge. That private hospitals are dacoits, we are fleecing people, we are overcharging, we are trying to maximize our revenues, etc., etc. My belief is that this stems not just from a distrust, but also from an anchoring point of view. In our mind, we are anchored towards what we are used to pay in probably a charitable hospital, or a religiously funded hospital, or a government hospital, because frankly speaking, till before the 80s, till before corporate hospitals came into existence, these were the hospitals which were serving society. And they used to charge only perhaps for the consumables, because the infrastructure and manpower, etc., were borne either by the organization which was supporting this charity or from donations and contributions. Therefore, we are used to paying only probably at 12 or 20% of the bill, which otherwise would have come in a full service hospital. If a costing exercise is done towards what is the cost of a specific surgery in a corporate hospital versus a government hospital or a charitable hospital which has to generate its own revenue, many studies have been done. AIMS had conducted a study in 96 or 98, I don't remember which year, and they had calculated the cost of a CABG to be 4,68,000 rupees back then. Private hospitals are pricing CABGs anywhere between 1.5 lakh onwards to 2.5 lakh or so, or maybe more. But the cost of doing a CABG in AIMS in a general ward was 4,68,000 rupees back in the late 90s. So there definitely is a cost to healthcare even in these so-called free and subsidized hospitals. Only thing is we are not paying it directly, we are paying it via our tax money. Either the taxpayer is bearing it or the government is sort of, government hospital is free is the funniest joke I have heard. I mean, how can that be possible? The issue is that no, it's not free. You are paying it, but it's in an indirect fashion. So that anchor, that when I go to a government hospital, when I go to a charitable hospital, then my cost is, let's say, 12 rupees. Why is it 100 rupees when I come to a private hospital? It's just because we are used to that 12, 15 rupees expenditure. So I believe that apart from the trust deficit that, hey, we are all not dacoits, it is also something to do with our disanchoring mindset, which also needs to be sort of modified. We as a consumer class have driven services businesses across. If you look at airline, we have taken it 24 in the last 10 years. If you look at hotel rooms, we have added probably 15 times the hotel rooms in the last 1 decade. All the service industries, by way of consumption, we have increased. Telecom, data consumption, any service industry, we have increased leaps and bounds by way of our consumption. And we have no issues in paying whatever is the listed price once agreed upon. But this one specific industry invites this discount stemming from a desire not to pay, stemming from probably a distrust. This, in my issue, is one of my favorite challenges, which I would like to ponder. Thank you for having me here.
Thank you, Prashant. That indeed was insightful, and I guess it's a problem which not only you are battling with. I think every hospital and every part of the country has this issue. So we would come back to that to see if there is any solution that we can find to it. And now may I request Dr. Ramakant Deshpande to share his view in terms of the most hard-pressing challenge that he sees in healthcare delivery sector.
Yeah, thank you, Dr. Richa, and thank you, Prashant. Something very interesting in connection with what you have been saying just now. I have a bill here from Stanford University for suturing an incision, a cut lacerated wound of less than 1 inch. That's very specific, which will cost them only $37,000. I hope you can start making bills of that kind. Yeah, but jokes apart, I think it's a very, very valid point what Prashant has brought up. I am actually exposed to a lot to cancer field. I spent my entire career in managing cancer in various parts. I was with the Tata Memorial Hospital for a long period of time in policy making decision as well as in patient care. And then I continued as a promoter of Asian Cancer Institute, which is a multi-locational kind of a center providing cancer treatment. So if you really see, one of the most major problems in any super specialty, be it the cardiologist friend of ours who gave a beautiful, beautiful lecture about importance of technology, very impressive, I must say that. Is one of the things is the human resource requirements. I think Prashant has already has mentioned everything about these particular thing in very general terms. But as far as specialty is concerned, see, if you take the magnitude of the problem, we have about 13.5 lakh new cancer patients coming up in this coming year, and this proportion will go to practically double that, almost about 25 lakhs in the next between 7 to 10 years. So we have approximately we don't have actually an exact count of the number of the specialists who can treat these patients. But if you take the number of people who are members of professional associations like Institution of Surgical Oncologists, Radiation Oncologists, Medical Oncologists, etc., the number comes to somewhere around 3,000 to 4,000 at most when you put all of them together. And the number which is required at this juncture is at least 2.5 times that. So you can imagine that. The number of centers is almost about 32 regional cancer centers and 250 departments of oncology, whereas actual requirement, like we have 30 states, for God's sake. I mean, at least one per state, if you say, then we don't even have even that. So we are very, very kind of under-equipped, understaffed. And it takes at least 10 to 12 years to make a good oncologist, be it a surgeon, be it a medical oncologist or a radiation oncologist. So this is not something that you can teach a person in 5 years, give him his MBBS and say that, okay, go ahead and do that. This, unfortunately, there has been we have different lines of oncology, like predictive oncology. What are the incidents of cancer that can come up, how a cancer will behave itself. But unfortunately, we don't seem to have a predictive kind of a policy, a healthcare policy, where you can actually predict the number of specialists which would have been required for treating these many number of patients. And the number of centers. Fortunately, now, with many of the leading centers taking lead, we have these post-graduation centers coming up. And I personally feel that any center which has more than 300 beds, where oncology is being trained, cancer patients are being trained, should actually buck up, and it should start making itself capable of becoming a teaching center. And this is very, very important, so that the doctors can be trained to become cancer specialists. It does not really need anything out of the world to become a cancer specialist, but it needs a very, very thorough kind of a training in line with whatever is the latest in the world. So one is, we need more number of consultants in line with whatever is really required. Number two is the nursing. It's most unfortunate, like, for example, we treat so many patients with major surgeries. Obviously, they can't really live in the hospital for too long. And then they go home. And then when they go home, if he has a large wound, suppose if I have done a lung surgery, or if my colleague has done a head and neck reconstruction, or somebody has done a radical prostatectomy, when they go home, they definitely need a good kind of a nursing care. And a nurse outside in a private kind of a setup, you will not be able to depend upon them even for taking a normal blood pressure. So it is most unfortunate that our training of the nursing as well as healthcare workers is just not really adequate. Thirdly, when we are looking at, if you don't have number of good anesthetists or good ward officers, etc., what I personally feel is the government has to take a serious look at this. In the US, also they run short of doctors. This is a worldwide problem. This is not only India's problem. This is a worldwide problem. So let's see how exactly they have sorted it out. They have created a category called nurse doctors. So for example, the anesthetist actually encourages the nurse to place a tube inside the trachea. Then the conducting of the anesthesia, the ventilator conducting, everything is done by the trained nurse. See, if you really analyze, the IQ difference between a doctor and a nurse should not be more than 20%. I'm not saying that being a nurse is any inferior, because it also needs a lot of human qualities, a lot of intelligence, everything is fine, but they are just not trained enough if you don't train them. So to improve the HR profile of all specialties, be it a secondary care or a tertiary care, we need very robust kind of a teaching, unyielding kind of a programs, which are very, very important. I think a lot of people sitting here are in actually decision-making ability. So we should not really accept anything really substandard at all, and try to improve the HR standards altogether. And not to take substandard kind of this thing. Just veering a little bit outside beyond my favorite topic of improvement of the HR. One more thing is, I think Prashant mentioned a lot of this financial structure. See, 80% of the complaints which come against any hospital, 80% of the aggression which comes is basically because of lack of communication. And the lack of communication could be from both, it's a compound kind of a thing. When a person goes into a hospital, for him, the doctor, the assistant, the nursing, the front desk, everything represents the hospital. So there has to be a complete coordination, and there has to be a complete training. So right from a turnaround time of the patient standing in a line for making a file to getting discharged after his treatment, all the processes have to be done very, very professionally. This is extremely important, which is not done in many, I would say 80% of the hospitals do not really follow this particular principle. And this is something which should actually be done very strictly. And that is not very difficult, mind you, if you apply your mind to these particular principles. Finally, regarding the financial structure, well, the medical fees are not really chargeable to GST. I think the governments have been very kind. But when you make a capital purchase, the GST is applicable. So if you can't have a setup against it, why charge GST on it? We had a repair for a building, and we put up recently, we improved the structure and the machinery of the hospital. We spent only about, it was a small amount, it's about 22 crores or something we spent, out of which 3 crores went into GST, which is a substantial amount of money. And where is this money going to come from? From the patients. So, and that actually keeps on going around in circles. So I think the governments also need to have a look at it, and they have to take this element completely out. I remember Dr. Naresh Trehan actually making a plea directly in front of one of the ministers with absolutely no reaction on the face. And unfortunately, though the administrative people, the IS people are very sympathetic to all these kind of things, they probably are not in a position. So these are some of the things which I feel are very, very relevant to improve the overall healthcare delivery in an organized way in our country. Thank you.
So thank you, Dr. Deshpande. You touched upon 3 very key areas. One, you spoke about HR, which is closer to your heart. Second thing, you spoke about communication, which is actually close to my heart. And you're absolutely bang on in saying that in my 23 years of experience of running hospitals, whenever you have had a problem or a patient has created any kind of a nuisance, the root of it is that at some point, somewhere, I think we forgot, or we kind of, we haven't really been very, very open about the communication, or the way it was communicated was not right. So couldn't have agreed more with you on that. And yes, GST point, when the GST was introduced, at that point itself, I think a lot of plea were kind of made, and people have raised this concern time and again, that if we can't recover GST, why is that it should be applied to us on different aspects. So very, very valid points. Thank you for sharing that with us. With that, now I would go to Dr. Ashwini. Dr. Ashwini, over to you to share your thoughts with us.
Thank you, ma'am. Thanks to ICC. Am I audible?
Yes.
Yeah. So thanks to ICC for giving this wonderful platform. Thanks to the esteemed panelists, and I will take up the further challenges. As far as my views are concerned, I would just like to throw upon few points. I have also been a clinician, have managing diagnostic centers, have been working in smaller hospitals and now in corporate hospitals, and especially in a metro city like Mumbai. So the various aspects are there. I would just like to highlight few which could be of importance to our august audience. And as far as now the present post is concerned, when we are in a corporate hospital, we know now the hospital industry is quite complex. It's multidisciplinary, it's pure service oriented, and a patient, we should always take care of the patient and the relative who are with the patient. So now I would like to call them as client, because they are our external clients and we need to satisfy each of their expectations. And thanks to the consumer era, thanks to a lot of awareness activities, the client is very well aware of his or her own rights. They know what services they expect, and we need to match the expectations. And when we are as a role of an administrator, we know it's very difficult to manage our own resident doctors, our consultants, staff nurses, our technologists, our technician, all need to work in synergy. Only then we can achieve this patient satisfaction. When we did a small study in ICU setup, and especially in a bigger hospital, we found few challenges which I would like to highlight and which would be beneficial to all of our colleagues also. In a big setup, there are key KOIs, many consultants, we give cross references to each other. A hepatologist will always say that the liver is perfect, okay, as far as my thing is concerned, his liver's enzymes are okay, I don't see any problem. Then a gastroenterologist will give his own views. Nephrologist will say, yeah, create acha hai, kidney is functioning well, everything is fine. Then the hematologist will give his or her own view. So many times after this multiple rounds, at the end, in the evening, when we go on rounds, the patient or the relative feels that they're quite confused. So what is this view? So is my patient fine? Is he not? And then we have that habit, medical legal, to keep ourselves safe. We will write liver is okay, the heart is okay, whatever dash is okay. So we as an administrator brought this concept of multidisciplinary meetings. So when we find that there are multiple references or there is something gone wrong, a patient and or relative wants some clarity, or there's some trickling has started that this could lead to potential grievance, we are in the multidisciplinary meeting. It helps a lot because all the clinicians come across, we sit, we have a meeting, we explain each point, and then we try to conglomerate all points. And this is one aspect of communication which every administrator faces issue. Whatever trainings we take, whatever we try and have a lot of modules for communication, even in this modern era, still we lack of communication at every stage. So especially at this consultant level, if we arrange such multidisciplinary meetings, it helps a lot for patient and the relatives to understand their condition. This was one aspect which I thought is important in a multidisciplinary hospital or in a era of where a lot of references are being given, wherein all super specialties are seeing the patient. Second, I would also like what pandemic has taught us is digital technology. So we all have now geared up. Like I could give examples of we had introduced digital pen. So this digital pen, when we are used to writing the prescriptions, you could say, or when we examine the patient, the consultants write with the digital pen. Technology is so beautiful that all the data gets transferred to the relevant stakeholders. Suppose if there's some patient who has been referred to MRI, the MRI desk or receptionist is quite ready, with the preparation. The lab is well aware that they are going to receive a patient for so and so blood test, so that we can make a nice experience. We can make a hassle-free experience after the consultation is over. So gradually it becomes difficult with doctors because we are used to our own systems. Some digital technology, if it is introduced as an administrator, it takes a lot of time for us to inculcate in our own colleagues. Next, also telemedicine definitely played a major role. But that thankfully in COVID eras, we all got accustomed, even patients got accustomed to that. And now in following appropriate COVID behaviors, we are all now able to serve patients, not only in our hospitals, we can have a lot of follow-ups, and also in the remote areas, we are able to access that. So one is, I would like to say, digital technology, the challenges were there, but COVID has taught us to adapt and to utilize it nicely. Third, I would like to, again, Dr. Alex has very beautifully said there's some factor which is missing in our curriculum itself when we were doing our own MBBS. So now as an administrator, we realize that there's something which is missing when our doctors speak to the patient and or the relatives. So there is something known as, which we have started, known as integrated clinical governance. We started training our own resident doctors. Those simple things like empathy, which is really missing. So we have to have it on-job trainings. We show them the modules. We show them various serials, which young generation like to see, the Western serials, how the doctor behaves, how he takes informed consent, how he explains the risk, and how he explains what all can go wrong, the pros and cons. Example, just now, the Good Doctor serial. The way they explain the patient and they make him or her comfortable, that thing is lacking in our resident doctors. So at least now we are all administrators. If we start somewhere, we'll be able, like when we are ourselves, be our patients, our young generation is going to have, are going to treat us. So this empathy thing, wherein consultants definitely are also training our own residents. Now we are available, but this young generation, we need to train. So this thing, integrated clinical governance, something which we have now started to train our resident doctors and definitely nursing staff and the other staff. So like to summarize, I would, this was the major things, because we have esteemed panelists after this. So we'll all like to hear the challenges from other sectors. So with this, I think I would end my small session. Thank you. If any queries, please let me know now or maybe later.
Okay. Thank you, Dr. Ashwini. Dr. Ashwini, a quick question that I would have for you, because communication came in once again, that how
Yes.
important it is. So I would like to know from you, when COVID came in the first wave, one of the biggest challenge which hospitals faced is that while earlier, when the patient relative comes in, he gets to meet the doctor, treating doctor, and he gets or she gets communicated about what's the patient status. Now that we had to restrict the visitors and they were not able to see their patients physically, the anxiety also increased in terms of how's my patient. How did Nanavati handle this problem? How did you put the things in place immediately so that this challenge can be addressed?
True. So we have these tabs in every small unit. We had multiple tabs across the hospital. So there were two things. One, we could do a video consultation, our own doctors. We used to have a video consultation. We used to sit with the patient, show how his or her relative, how the patient is, and immediately communicate. We used to have this video, this tab consultation. And immediately after, when we used to, the doctor used to speak to the relative, we used to document in the notes that we spoke to so and so patient, because at such times we have a system known as family counseling. So at this time, there is no relative to sign, to acknowledge that what points we have explained to the patient or the relative. So in two cases, in stable patients and in ICU patients. In stable patients, when we used to speak to the patient, the doctor used to speak to the patient, or the consultant used to go and take rounds, he used to ensure the patient signs. At the same time, make a call with the relative with the tabs. Multiple tabs at multiple areas in small units we had. So the relative used to be reassured that yes, I have seen my patient, I have seen my patient with my doctor. Second, as far as the ICU is concerned, same philosophy used to follow. Twice a day, we used to take morning, evening. The tab used to go with the resident doctor, the consultant also. When they used to go for rounds, we used to show the patient, we used to show the parameters, and when the relative is satisfied, then we used to again document it in our notes that so and so counseling has been done. So this technology definitely helped the ease and definitely helped the patient satisfaction.
Sure. Good to know that. Thank you.
Yeah.
Now we would move on to Dr. Kaushik Murli. Dr. Murli, are you around?
Yes, ma'am, I'm here. Are you able to hear me?
Yes, I can hear you clear.
Sorry. Apologies. So I've logged in from my phone. There's some connectivity issue, challenges with the virtual meetup. So here I'm going to share with you a kind of a different problem coming from an eye care field of a high quantity, high quality kind of efficiency that eye care necessarily needs to deliver. And coming from an eye care organization, a network of 12 eye hospitals, unfortunately, I'm going to have a very myopic single specialty kind of a perspective. And I must congratulate the office bearers of ICC for putting together such a very diverse panel with diverse perspectives that we hope that the audience can gain from. Now, amongst the cardiothoracic and the various other multi-speciality, a 20-odd gram organ, why should we even care about it in a national health summit? Well, it's all about the numbers. So the IAPB put out this data of India having about 270 million who are visually impaired and about 9.2 million who are blind as of 2020. And to serve this, we have about 15,000 ophthalmologists across the country. Why is this still a challenge? Because the temptation is to look at a one-size-fits-all when it comes to healthcare. So we are always quite prescriptive when it comes to the model of care that needs to be delivered. But we need to understand and acknowledge that there are multiple versions that are required, especially if you want to ensure equitability in healthcare. So while you need the larger tertiary setups and you need the primary care, you need some kind of a bridge model, like Dr. Alex mentioned about the mission-driven organizations that can kind of provide an outreach to those who are unserved. And organizations such as ours are able to fulfill that. So over the years, we've been able to do about 2.3 million surgeries free of cost to underprivileged Indians in following a doorstep-to-doorstep model. So while we've been following this high quality, high kind of quality model, the other end came when accreditation and regulation came into play. Where that threw a challenge at us was in terms of the kind of human capital that we had to look at. So it was not enough for you to look at somebody with qualification and capability, but you needed to get somebody with a particular qualification. And at some point, I think we need to realize that specialized healthcare with some amount of qualification are probably better served than getting people with just a generic qualification. What do I mean by that? Following a 1:6 ratio of a nursing staff in an eye hospital is a waste of resource. Dr. Alex spoke about the brain drain, and we're aggravating this problem by using resources inappropriately at times just to comply with certain accreditation norms. So is there a way we could actually have the entire industry refocused and repurposed, saying that can we look at these staff differently? Again, when you look at, say, quality implementation, we need to look at people who can multitask. That's something I think we as Indians are inherently good at. And when we talk of multitasking, it's not just doing something at the cost of others or compromising. So our entire quality initiative across the 12 hospitals that today are NABH accredited is driven through a quality assurance program called Sankalp. So I'm a part clinician, part administrator. So most of us can actually double hat quite well when it comes to these specific aspects. When you look at human capital, again, the challenge comes with technology. So Dr. Ashwini spoke about how technology has become an imperative, especially in the post-pandemic scenario. Enabling our staff to handle technology. And again, the other valuable aspect she shared was how empathy is critical. So we've been using AI-based solutions in trying to screen for eye conditions, but patients are not happy with just a technology telling them they have a problem. They still want a human interface. So how do we retain that humaneness when technology is at hand to provide a very easy solution? So again, that is where the HR training becomes very, very critical. And the last bit that the COVID has again thrown at us is this hero versus anti-hero kind of a balance. Do we want to be put on a pedestal saying doctor is God? Probably not. At the same time, don't bash us saying that, you know, we are the villains. So somewhere there needs to be a middle path. And today, I think the new generation of doctors that are emerging come out with the belief that they're probably getting the short end of the stick. So the entire purpose with which most of us enter the medical profession today somewhere seems to be diluted. And again, probably I come with blinkers on, coming from an organization with a complete social ethos. But I think it is very critical for us to remember that as healthcare providers, that quality is critical, quantity is extremely critical, and it is up to us to take leadership when it comes to this. India is a land of problems. India is a land of large population, but India is also a land of opportunity. So can we actually collaborate at some means where we have bodies like ICC bringing us together? Because quite often we all function as silos of excellence and we don't cross-learn from industry. So there are very few platforms where we have healthcare administrators talking to each other, sharing best practices. So is there a way we can not only collaborate, but also co-create solutions for India? So with that kind of a thought of challenge and probably questions, I thank you for inviting me to be a part of this session.
Thank you so much, Dr. Murli. I think the last part which you said, I mean, while I agreed with all that you said, the last part which you said is something which resonates with my thoughts very well. Is about that, if you look at the panel right now, we have got some of the best hands, who are running hospitals themselves. And there's so much, as I said, and that's the reason I decided on this format, so that we can also learn from each other, right? Because we have, you come from a single specialty. Dr. Deshpande shared his experience with oncology. There are a lot of people from multi-specialty background. And while we are talking about the challenges, it feels like as if it's my problem too, right? And I'm sure everyone would have found an innovative solution to their problems. So yes, I think I would request to ICC that if there could be a forum where, like the hospital administrators could be together and can interact more often. So that's a good idea for sure. If I could quickly ask you one question, Dr. Murli, which may not be purely a challenge or a long-term challenge, but something which COVID would have enforced on you or your system. See, what happened is, especially for the first wave, what we noticed is as the COVID started to come up, right, people were scared coming out. Okay, and of course, I mean, it was also a directive that not to come out of the houses, but of course they could come out for seeking healthcare. right? But what we saw is that apart from some of the key specialty where the treatment could not wait, it could be fatal. So whether we talk about something chronic as problems related to nephrology or oncology, many of the patients held themselves back from seeking treatment. And I would like to assume that it would have happened significantly for the optal care, right? So how did you come out of that? I mean, did you do some kind of a campaign, confidence building campaign, or did you tell them that this is something which cannot wait? It could actually further hamper your eye health. How did you go about that?
So we did two things. So one is we try to learn from industry. When I talk of industry, we interacted with certain peers from outside of the healthcare. Because like you rightly said, there was no need for people to step out. And if they were stepping out and patronizing certain industry products, why were they doing that? So the customer insighting that we learned from other industries was very, very insightful. So there were some key trends that came out. One was, if you look at the Doordarshan, Ramayana was the most popular. Why was that? There was a sense of familiarity. So people were looking for, grasping for something that they could remember and be, were familiar with. The second aspect that was very critical was there was a need for people to be, loyalty was a big, big factor. So even when we surveyed our staff, they felt responsible as healthcare workers. Although in eye care, we were not technically frontline, but they felt important that they needed to come. So there was a need for us to reach out to those patients who were loyal to us and were coming despite the pandemic. The third aspect that we realized was very critical was safety was very, very paramount. So we needed to put together a program that not only made our patients feel safe, but also made our staff and their families feel safe. So we came up with something called a SPARK that looked at social distancing, that looked at protection, which was task-based. We looked at guidelines that were dynamic and changing by the week, that we needed to figure out where to regulate patients coming into our hospital. We need to look at technology. And we had to do multiple such initiatives. What we also started looking at was looking at technology differently. So we had a much bigger push looking at AI-based solutions that could help us in identifying and at least triaging patients. And we also looked at, built on our outreach model. So we had outreach camps that we used to conduct. So we were not averse to being out in the field. And we had set up certain vehicles that used to be able to do all kind of like a mobile vision center of sort. So we blended in technology and said, look, people are not just happy being screened, but they want to interact with patients. I think all the other previous speakers also kind of alluded to that. So this gave us an opportunity to test some of these models and see, saying that, will it work? And what came out again is saying that you can't have a single solution. You need to continuously innovate. It's not just enough being impactful, but somewhere you have to draw on inspiration. And what is scary is people with chronic diseases, hypertensive, diabetics, sitting at home, somehow they seem to be very scared reaching out to hospitals. I think towards the fag end of the second wave, what I would like to use this platform to reaffirm is hospitals are probably the safest place for you to be in. Because here are professionals who understand infection control, and we are scared of carrying infection back home. So if not anything, we want to make sure that you don't infect us. So if you have a health problem, reach out to your hospital and get treated. And probably that kind of a communication needs to go out. The last couple of weeks, things have been looking up. At the same time, it's a little scary because people suddenly seem to have forgotten that we are in the midst of a pandemic.
Yeah, very well said. Thank you so much, Dr. Murli. And with that, I would quickly move on to Dr. Subhrajyoti.
Hello, Dr. Richa.
Hi.
Hi. So at the outset, let me thank ICC for inviting me here. And, my previous speakers have really picked up a lot of important issues, but I'm going to actually highlight 3 issues which I think are very, very important challenges. And the first one I would say are, the awareness of patient safety in the healthcare systems. I think we as doctors, the nurses, even the pharmacists who work with us, this orchestra of people are not sensitized to the patient safety concept, which we are expected to learn overnight as we embark on the journey of accreditation, because any of the accrediting bodies require it. But this is the chicken and the egg story. Unless and until we have the egg, we can't have the chicken. So who teaches us patient safety? I was just going across the internet today, and I was surprised to find that for a country like India, which has close to 67,000 hospitals, and employs more than lakhs and lakhs of healthcare professionals, we still don't have 10 institutes in India which train us for patient safety. And we were just talking that, all the medical legal litigations which the hospitals have are because of lack of communications. But the lack of communication leads to patient harm, which results the communication to flow into very bad direction and resulting it to go into the sometimes to medical legal litigations as well. So what is the solution? I mean, how do we do this? So I think platforms like this, and especially institutions like ICC should immediately join hands with the government to have a patient safety environment consciousness as well as training initiatives across the country to make our staff aware. And this is not only about hospitals which are in Kolkata or Mumbai or maybe the Fortises or the Apollos. I'm talking about the tier 2, tier 3 cities and where the majority of the population resides. I am yet to find a government which has a state patient safety officer. Why don't we have that as one of our focus areas? This is one of the major challenges, I personally believe, because unless and until our patients are safe, unless and until their people feel that they are safe. And my previous speaker mentioned that hospitals are safe places. With due respect, I would like to differ on that. I think the most dangerous places on earth are hospitals because the lack of standardization make it more dangerous. And the good hospitals are one which have standardization of approaches. So this is an extremely very, very difficult area in a country like India, which is still evolving from the concept of accreditation because it's only 10 years old and it is still being focused in, I would say, few hospitals in the country, yet the majority of hospitals have not been embarked on that journey. So that is one of the area which is major challenge in the country. The other one, of course, Dr. Deshpande and my previous speakers have mentioned is human resources, but I want to focus on a specific human resource, is the pharmacist. I would say that if you really ask, we did a study and among the pharmacists who are graduating from the undergraduate as well as the postgraduate institutes in Bengal, and we found out that majority of them want to go to pharmaceutical industry. They don't want to come to the hospital. Why don't they want to come to the hospital? Because there is no roadmap for them. Don't we require good pharmacists? Is pharmacy all about dispensing? That is a question we need to ask. We had a wonderful session about drug procurement, about accessibility. But let me tell you, and let me share this with the august audience here, that majority of the best brains of pharmacy are still and they are engrossed or they are taken away by the Indian pharmaceutical companies or the MNCs. What we get back are people who are doing nothing but except dispensing. Can they not be involved in reducing medication errors? And I'm again not talking about the handful of hospitals. I'm talking about overall hospitals in India. Majority hospitals have never given the pharmacists their due. So this is another major important aspect which we need to focus on both in government as well as non-government hospitals. Lastly, I would echo Dr. Richa what you said, communication, but I would give a different angle to communication. Lack of communication with the media. It's an extremely important player. The media paints us villain when we do the wrong things, and majority of the time the people who are reporting have no idea about how healthcare works. I'll give you a small example that they will never ever report if a good incident happens in a hospital, the hospital name. But even if something goes wrong, they will report the name on the front page. We need to actually, I think these platforms, we need to utilize to increase our communication with the national media the regional media. And I can tell you this because media is actually, and the reason, the root cause is being a quality professional, I would say the root cause is that majority of people who are doing medical media reporting are not doctors, or they are not trained in healthcare administration, or they never went to a hospital administration college. In countries like United States, where I spent some amount of time, there are universities like Stanford University, Dr. Deshpande mentioned, who have courses for medical professionals which are in specialization in media. Why can't India think like that? Why can't we have doctors who can dedicate 1 hour of their time to communicate to media? Because in majority of the hospitals, we see that the marketing professionals, they talk to the media. I think a high time has come where, as my previous speaker mentioned, we need to wear multiple hats. The healthcare administrators need to handle media very effectively, because ultimately they are the most powerful voice and they are the most powerful game changer in this country, whether we like it or we don't like it. And lastly, I would end by saying that we are capturing a lot of data as accredited hospitals. Ours is an NABH accredited hospitals. And NABH or JCI, I would especially say about NABH, was supposed to bring about a national benchmark. But I think that is one area which has not evolved over a period of time. So within the NABH accredited hospitals, we don't know who's better, who's the best. I think time has come where we must share our internal reports, though they are anonymous, and try to learn from there and try to have some kind of a benchmark to begin with at the city level, at the state level, and finally the aspiration should be at the national level. I think with these challenges, these are few challenges which can definitely be addressed to make our hospitals more safe, our hospitals more acceptable than the government hospitals, if I could say that.
If I read the body language from the organizing team, which is Madhupurna and my dear friend Prashant, there's clearly an indication that we are running short on time, right? And we have got 3 more speakers to go. And so what we would do is we would like to shorten up time a bit. And I would request Suparna to go. And Suparna, if you could share your concerns in terms of the challenges, and also if there's any solution that you've been able to find to that.
Thank you, ma'am. Good to see you after a long time. Let me
Absolutely a pleasure to see you.
Yes, take this opportunity. I'm just taking this opportunity to say hi to you. Ma'am, like since we are running very short of time, the most pressing thing which I personally feel, being in the industry for so long, is that we are absolutely not geared with preventive healthcare. We are only bothered with outcomes. I think India is facing such a big challenge. Because of this pandemic, this is something, the story is different. But I think we are not at all focused on preventive management. Suppose we could have done a lot more on preventive management. Then I think if we had not been more bothered about the outcomes, but on prevention, then the cost factor, which is so much we are discussing about it, starting from Mr. Prashant, I think I will echo his word. I think this is one of the pressing points which we all as administrators are facing at this moment. So everywhere there's a capping, people are having mistrust, they are thinking that we are charging a huge amount. But then if you are continuously screening yourself, you are taking adequate precaution to keep healthy, then we should be rather concentrating on you to take care of health, rather than treat you in an ICU when you are absolutely bad and the costs are skyrocketing. So the government has to take a lot of initiative, but as private players, we also have to take a responsibility towards it. I think that the insurance sector plays a very, very big role, because still now, most of the insurance is only dealing with inpatients. There's nothing for outpatients. Suppose you go for a dental checkup, you are not covered. You go for this, you want to see a doctor, you are not covered. You want to take a battery of tests, you are not covered. So this keeps most of the individual back where if we see, the data, almost 60% of our savings are spent on healthcare. So people are skeptical about spending this huge amount on preventive management. So if the insurance can come forward, take this as a challenge that, we would be, say, let's take this next 5 years, on preventive health for all, health for all by 2020, something like that. So why can't we do this? This is one thing which, which I personally is very something which really I think about it. And the second part, second point is what Subhrajyoti has said is media. I think we are only going to the media as hospitals when we are cornered, or when somebody raises allegation, or when we have to counteract, when we have to say, why can't we say it from before? Why are we so media shy? Why can't we brief media what we are doing? What are the new advances we are doing? Suppose we have opened our hospital, we are new hospital. So we have a lot of challenges which are not being faced by the older hospitals. But we are so media shy, we always think, okay, theek hai, let people talk and then we are going to go with our answers. So I think this communication part is hugely not looked after, So we need to, our doctors can spend time in talking to the media, because yes, they are the game changers. Lot of things goes around, and before we can take a action, people start believing. So, it's like a situation where you are always answerable and you are looking here and there. So I personally feel that if the communication, this part of the communication has to definitely increase if you have to do something with the healthcare. And the third point, which is a very big challenge, is I think most of the speakers mentioned, is when the cost of the healthcare definitely goes a little high, because when we are not in a position to, for all the goods which are imported, the trade margins are not rationalized. So I think a lot of, infrastructure has to be built up on this aspect, so that we can rationalize the pricing. So we are only catering to the, need of the patient. So we are on the last part. So before that, the GST is coming from the direct point to the distributor point. So I think this is something, but this is not the forum. It's just a point to be picked up, and it takes a massive amount of discussion and policy giants to, come to our help. And EHR is a very, close, what to say, it's something very close to my heart. So I feel that suppose we would have developed ourselves around the EHR, lot of repetition of tests, repetition of, suppose I am getting treatment at Calcutta, I want to go to Chennai, I want to see a doctor there, I have to carry the entire staff. Why can't something be, done where, I don't have to go and repeat this. My diagnosis is fast. My doctors have, access to all my electronic medical records. Why can't we have a system like the West? Why do I have to carry all my files and my documents and go around, and if I miss something, I'd be asked to repeat a test? Why this? Why such a waste of time and money? So, and delay of diagnosis, and so the cost, multiplies. So I think these are the 3-4 points, ma'am, which I would like to, present it before the forum. And thank you, ICC, for this opportunity. And let's see, how far we can go. I think there's a long way to go.
Thank you, Suparna. I think, yes, all of need deliberation and solution as well. So all valid point raised. With that, now I would move on to Dr. Gitika Madan Patel. Thank you, Dr. Gitika, for joining us. Over to you to share your challenges.
Thank you, Dr. Richa, for having me. This is really a nice opportunity to share the perspectives. So I know we are running short of time, so we'll quickly share my perspectives. Most of the challenges, though, we can all relate to each other, and most of these are common. So I'll quickly brief what the challenges which have not yet been covered is. The last speaker was telling something about the EHR. Adding to that, I feel that Dr. Sarkar was mentioning about the lack of policies which we have. So, you know, the policies, we definitely need stronger and better policies. So for better policies, we need a lot of groundwork and homework to be done. And all the groundwork, it comes from data. So what our country is lacking currently is the data related to the diseases, the prevalence, the incidence, the morbidities, the mortalities. So we very urgently need disease registries, which we currently don't have. If you want to know what is the number of cases in a particular place, in a particular district, we have to depend upon the prevalence study which are conducted in sub pockets. But we do not have central registries of, say, venous thromboembolism, how many people get killed by sepsis, how many people are killed by cardiac arrest. So centralized disease registries are something which I feel is of utmost importance, because the data they will give us will help us formulate policies. They help us build up the concrete plans for coming years, and that actually helps us know that how many specialists in which particular areas are required. Currently, whatever data we have are based on NFHS data, which are conducted not very frequently, and they have their own issues. So the disease-based central registries is something which I feel is of utmost importance, and that is a challenge which we face most of the time in formulation of policies. We had a medical college a private medical college in Baroda here. So a very common challenge which we are facing right now is the lack of basic doctors. So if I hire an MBBS doctor today, maximum he will stay for, this is the second challenge now I'm coming to. So the stability of doctors and the attrition which we are facing. So an MBBS doctor is a basic ward officer who manages our wards, who manages our OPDs at certain times. So he or she is a person who doesn't stay more than 6 months because he's studying for the postgraduate examination. Now this trend has come up to postgraduate students, postgraduate residents who come up and join after their MD and MS, and they also now attrit, and they also now move away after 1 year because they are all studying for super specialty. So I see a very difficult and strange situation coming ahead is that we all have all super specialists, and we will not have MBBS and MDs, sufficient number of MBBS and MDs, because if they don't get admission in one particular area, they keep studying for it for further 3 or 4 years, and that is a time when we are lacking into the specialist doctors. So today I've already started facing difficulty in finding a physician. I can easily find a cardiologist, frankly. So this situation, it has started, but I see it expanding and broadening in coming time because everybody wants to be a super specialist. So if everybody is a cardiologist, then how will the physician, and how will we find the physicians or the medical officers, which we say? So there has to be a triangle, as in we need in the base of the triangle, the maximum number of people needed are MBBS doctors. Somebody very correctly mentioned that we are increasing the seats, but at the same time, everybody wants to go to the top of the triangle. In the triangle are the super specialists, which is required as the tip of the triangle. But today what is happening is everybody wants to go to the top of the triangle, and we are really facing difficulty in finding the MBBS doctors or the baseline, now even the specialists. And the third challenge, quickly, I feel as a public health person, because I'm trained in public health, and as an administrator, I feel is at one hand we have hospitals which have JCI accreditation, which have NABH accreditation, and at one end where we have the hospitals, the smaller centers like PHCs, the primary healthcare centers, and the health and wellness centers. Now we really need to revamp them. I feel that they are really not doing good, and what our stakeholders feel that increasing the MBBS seats and putting a doctor at a primary healthcare center will solve all the issues. But when we see the ground reality is, many times we see that there is only a doctor in a PHC who is sitting and running an OPD. He does not have a proper backing by trained paramedical staff, trained nursing staff. He does not have a delivery room to conduct deliveries. If he has a delivery room, there is no one to take care of the patient in the night time. If he has an operation theater, the machines are not working. So an entire ecosystem which is required to make a small health center functional, the stakeholders need to realize that it is an entire circle which needs to be completed. And the presence of only an MBBS doctor or even an MD or MS doctor cannot help the the purpose of catering to that particular village or that particular district. So if we don't realize the entire circle and the exact requirements which are needed to make a small health center functional, and if we don't make the plans to put on paper to complete that entire circle, it is really very difficult, and the medical colleges, the district hospitals and the tertiary care hospitals will keep overburdening, and these smaller centers will just keep lying like unused infrastructures with a doctor who does not have work, with a few nurses who are just sitting and maintaining some data to submit to the authorities. So these are the three challenges which I feel were not covered earlier. So that is the reason I tried to highlight them. Thank you again for giving the opportunity. Thank you.
Thank you so much. I think you touched upon very crucial points. So when you spoke about that, we not getting MBBS or even MD doctors, I guess that's again pretty much across the table that everyone faced that problem. And you being the public health care person, you exactly have seen how PHC gets run and how CHC gets run. So just mandating that every student after clearing MBBS has to go and serve in the village or rural area would really not help, unless otherwise they also have system to support and people to support. Absolutely agree with you, Dr. Geetika. Thank you so much for sharing that. And now we have Ms. Upasana Arora with us. Ms. Upasana, thank you for your patience. You being the last speaker, please feel free to whatever you have to share without being constrained on time. Thank you so much. Kindly go on unmute. Yes, yes.
So thank you so much. Good evening to everyone. And when you are last speaker, so half of the people already told everything to everyone. But still I have something to say, because healthcare sector is a sector which is full of challenges. I think we are facing.
I think she has gone on mute. So
yes.
So am I audible now?
Yes.
Yeah. So our industry is facing all types of challenges which other industries are facing. But we are facing more because we are into healthcare, and healthcare means matter of life and death. So people are coming to the hospital with very emotional phase. Nobody is coming with the happy mood. Only delivery patients are coming. Otherwise, so everyone who is coming to a hospital, that person is not in a good emotional state of mind. Or when somebody is going to a restaurant, that time he is very happy and he is not having any problem to pay bill. But when somebody is coming to the hospital, he is always facing lots of problem in hospital when time comes to pay bill, as my first speaker, Mr. Prashant, has said. So all other speakers are told everything. But what I feel that right now, most biggest challenge for healthcare is to revamp our image. People has painted us as our, I think one of our speakers said that, Subra Jyoti said that media is painting our image as a villain. Actually, so not only media, people are also thinking about healthcare facility, doctor and hospital as a, as a bad boy or as a bad place. I don't know why. If something goes wrong in any place, then it is like that everybody is thinking about every doctor and every hospital, that these people are manipulating things. So I want that right now it's high time to, with the help of our associations, we need to revamp our image, that we are there to help you. Even at the time of Corona, when people were dying because of Corona, still people were, fighting with the healthcare workers, with the doctors. They were creating lots of ruckus in the hospitals. So I really feel bad, because, we do work by heart. We feel the pain of our patient. And when we are not getting that kind of respect, I am into this in this field from decades. So I know how things are changing. There was a time people were saying that doctor is a god, and now people are saying that they are to just making money. So I really want to change this image. And same time, because of this second wave of Corona, our medical tourism is going to be very, very hampered, because lack of oxygen, and our New York Times and other magazines has just put our funeral pictures like whole India has gone now. So India was a destination for others, that it's a cost effectiveness and best healthcare, because Indian doctors are the best doctor. I think UK and US run by Indian doctors. And still right now we are, we lost that kind of image that India is the best place to go. So we need to revamp our image, and same time, as all our other speakers said, it's a, healthcare is a place where everything is knitted with each other. Like HR is very important, like communication is very important, there is a, cost is also very important. And we are not getting, healthcare is not getting any incentive from government. Other industries are getting lots of incentive in form of, like manufacturers are getting something, service people are also getting something like in form of SEIS or something. But for healthcare, running a healthcare facility, no subsidy. Even FAR is very different in different states. So nothing is in a uniformly done for healthcare. So everybody should get ease of business. If somebody is putting a hospital, he has to face lots of challenges to run that. Same time, when your patients are not happy with you, then healthcare facility, how we have to encourage our people who are working for us, our nurses, our administrators, our doctors. This is the lacking right now from society. So I really wish if ICC can help us to present this webinar in form of our all our experiences, that what we are thinking and what we are facing. Because if right now we are not able to manage our image, or we are not able to manage all these things, so there is a third wave who is about to reach. It will be very difficult for healthcare workers to work in that kind of stressful atmosphere, because healthcare already, you can understand somebody who is working in healthcare facility in a hospital, he is not all the time happy, because he is all the time dealing with pain. And if he or she is all the time feeling afraid that somebody can come to beat me or threaten me or something like that, it's not a good thing for everyone, not for healthcare workers. I think it's not good for society. So we need to change people and public opinion about us, and we need to provide healthcare people some extra privilege in form of some incentive, and some insurance company should do something, or government should provide some kind of preventive health checkup to others. So there should be less load on healthcare facilities, less load on healthcare workers. And we are human beings, we also need some peace of mind, not only all the time stress. That's it. And I don't think if we will continue this program, there are lots of things which will come up. Like healthcare is a bundle of problems. So it's a complex place, and it's lots of problems. So we need to resolve one by one. And I am very positive thinker. So maybe one fine day we will reach to that place where everybody will praise healthcare facility, because nobody can live without healthcare facility. One should understand that we are essential. Thank you so much.
Thank you, Upasana ji. Yes, I think you spoke from heart and your experience. So thanks so much for sharing that. And I would like to once again thank all the panelists for sharing their insight and some of the solutions that came up with that. We're running short of time, and now I would hand it over back to the organizers to take it to the next session, please.
Thank you, Ms. Devgupta, and thank you to all the panelists for their deliberations. We would now quickly move on to plenary session 2, healthcare investment and boost of Indian economy. And I would like to first announce the speakers for the session. It's Mr. Prashant Sharma, MD, Charnak Hospital, Calcutta. Mr. Pradeep K. Jaisingh, Founder and Chairman, Health Star. Founder Director, International Oncology and Managing Trustee, Out Cancer Foundation. Mr. N.S. Vishwanathan, CFO, M-Fine. Professor Francesco Paolucci, International Speaker, Professor of Health Economics and Policy, Faculty of Business and Law, University of Newcastle, Australia, School of Economics and Management, University of Bologna, Italy. Ms. Akriti Bajaj, Assistant Vice President, Healthcare Lead, Invest India, and Ms. Neeraj Kulsheshta, Chief Regulatory Officer, BSc Limited. I would like to hand over to Mr. Prashant Sharma to take the discussion forward. Over to you, sir.
Thank you, Irene, and very warm welcome once again to all the panelists. First of all, Risha, thank you very much. You just gave me a very late start. Being a true friend, that you made my job even more difficult. Thanks for that. So, in the interest of time, I'm going to sort of speed through our way through this. So, we'll try and conclude as early as possible, because I want to leave it at a better place for my next panel, which is moderated by Dr. Ashwini. So let's try and do a fast, rapid fire sort of a thing. Good point is that we have a lot of great speakers here who are adept to a lot of speed modulation. So we will just go one by one and try to make it as fast as possible. Let's keep a target around 7:40 is when we will like to conclude, so that we are sort of, in the interest of time. So all my panelists, kindly do cooperate with me and do tolerate me when I budge into your time frames. So we'll start with Mr. Jay Singh. Mr. Pradeep Kumar Jay Singh, please go ahead, sir. Mr. Pradeep Jay Singh, do we have you online? Yes, we do.
Yes. Good evening, everyone.
Yes, good evening, Mr. Jay Singh. You can please proceed.
Okay, so thank you very much. First of all, I would like to express my thanks to the organizers and for organizing this summit. The topic for today's session is on the environment and opportunities and challenges in healthcare investment. And so I have been very closely connected with this space for quite a long time. First as an entrepreneur, and then now for many years as an early stage investor. So we've really looked at it from up close for many years. I could also share a small presentation, and yeah, so in terms of opportunities and challenges in healthcare, if you look at the areas that, I mean, these are some of the slides capturing some of the investment we have done over the past years. But obviously, the macro story in healthcare in India continues to be very, very attractive. But the problem has been in terms of both availability of very early stage capital, where some of the initiatives like healthcare accelerators, where Health Start plays a role, that has been a challenge. Plus, also, I think COVID has made it rather difficult. On one hand,
may I request you to please make it on slide mode, the full screen mode, and also because you have 27 slides, so I'll request you to go a little bit faster. Please.
No, I don't. I would not cover all these slides. Just
so visibility, if you can kindly make it full screen, it will be more visible to the audience.
Okay. Just one second.
You can just press the bottom icon on the right, next to the light.
Next to this,
Brushes like glider at the bottom of the screen. Just the little fourth from the right.
no one next to the Zoom slider.
Just 1 minute. You need to first enable the editing mode, the one that is coming on the top ribbon,
Yes,
and then
yes.
you need to press the slideshow button. The one where protected view is visible.
The
Then
yellow
only you
ribbon on the top. You have to press enable editing first. Yeah, and now you can press the small slide button on the bottom right. Not one, come a little left to that. There's come a little left. Yeah, first button on the left. The next one on the right. The next one, yeah, that one. Perfect.
So obviously the healthcare market story, I think, is familiar to all of the audience here. The macro story continues to be very good. What we are interested really in terms of how the focus has been more on digital healthcare initiatives and technology-enabled healthcare. COVID time, at the time of the first wave, almost everywhere, there was big focus on the technologies leading to some of the COVID solutions, and which was understandable. But what happens in entrepreneurship, you do not just do a knee-jerk reaction, and so temporarily that might be useful. And then the question is, how quickly can you take it to the market? The same thing happened in the second wave. Almost the entire country, unfortunately, because of the oxygen concentrated shortage, started focusing on that. Now, of course, that needs to be done. That is the must-have situation, but not necessarily an opportunity for entrepreneurship in such a emergency and crisis mode. So that was the second problem. So overall, in this past 15 months to year and a half, I would say the problem has been of quality deal flow. That is not the problem we are seeing in other sectors, but in specifically in healthcare, that has been one specific challenge. But of course, despite that, the digital health situation across the world has been robust, and three areas where, from early detection to chronic disease management to areas like oncology, neurodegenerative diseases, and then also health and wellness space. These are the three areas that are seeing tremendous amount of interest. And in India, we are following the same kind of a trend. So investment in any Indian healthcare startups, saw some dip, but again, I think we would see increasing interest in digital healthcare and technology-enabled healthcare going forward. That is the trend again. Essentially, if I were to look at one area which is of specific interest to me, is that within India, there are very, very diverse scenarios. So we continue to see largest amount of entrepreneurship from areas like Bangalore and NCR and Mumbai. These three continue to be the leading destinations. What we have not seen enough of is the entrepreneurship coming from Calcutta and the eastern region, for example. And I was there in Calcutta, a few years ago, and I mentioned that same thing that time. But I think we need to really see that part, being supported, being developed and nurtured more, because healthcare need is universal. And in fact, to some extent, the need in eastern part of India is even more. Even big cities like Calcutta, now of course the situation is much better given the number of hospitals and all that. But in areas like oncology earlier, we had a challenge. And now across the region, of course, entire Northeast, then states like Bihar, rest of the West Bengal. Again, I think, so a lot can be done now to leverage technology and enhance access to healthcare, improve the quality of healthcare access, and then also enable people to be diagnosed early, in different geographies, and then something can be done about the quality of care and the treatment. So that's something that we'd like to see. Both ICC as well as other organizations within the region can look at supporting something there. So opportunities, exist across the spectrum: pharmaceuticals, medical technology, insurance. I think there is a session following this on insurance. This is a big ticket item where a lot of work can be done. Out of hospital care, I think this is going to be a very interesting area and a big ticket item, even in post-COVID scenario, because as we saw very quickly, we were overwhelmed as a country by the COVID pandemic. And we need to be able to provide almost the same quality of care to people outside the hospital. And so therefore, remote care, remote ICUs, remote post-operative care, all of that is just a tremendous opportunity. And so in terms of medical technology, what kind of technologies? Remote monitoring, I mentioned. Point of care diagnostics. Now, that is very important, where technology can play a role, because, in pharmacies, in other diagnostic centers, and in India as a country, the user behavior is also such that a lot of people just go to the neighborhood pharmacy, try to get diagnosed, try to get treatment. So we can enable even that infrastructure for better adoption and wider adoption if we can deploy appropriate technologies for better diagnosis, quicker diagnosis, and more accurate diagnosis. Then continuous monitoring, wearables, of course, around the world, that is a huge area that is seeing traction and has seen. I'm not just talking of Fitbits and things like that, but Apple Watch enabling large number of variables, measurement data from specific companies coming into areas like sleep, to continuous glucose monitoring for diabetes, and then now wider scope, not for non-diabetics, but across the population. Then also on surgical side,
sorry,
minimally.
I'm sorry, please excuse me for butting in. May I request you to kindly try and come to a shorter closure than what we would normally expect from a lovely speaker like you, because this is an instrument which we can stretch for a long time. But in the interest of time, and a lot of other speakers are there, may I kindly request you to keep it short, please. Thank you, sir.
Okay. Yes. So I think please go ahead and continue. These are some of the things that I had to share. Thank you.
Thank you, sir, for being so accommodative. And I'm sorry to be so rude and button, but I have to. It's a job, and its chair demands it. So,
no, I appreciate it. Thank you, and all the very best.
Now, Vishy, I know that you can modulate and you can go super fast, so I'm going to give it up to you and all yours.
Yeah, sure. I'll do that, Prashant, in the interest of time. I was supposed to come to Calcutta for this. I decided, since it's a hybrid healthcare summit, so I will speak about hybrid healthcare from home. That's why I didn't travel from Bangalore. Thank you for this opportunity. I'll just take 2 minutes of an introduction to what I'm planning to speak. Before that, I heard a lot of people here, and was very well to see people talking about patient engagement, data, technology, AI, telemedicine, preventive care. So very nice to see in a forum like this where healthcare professionals talking about these terms. It really whelmed me in terms of getting to my topic, which was very simple. So what I was here talking here is we have been talking of telemedicine and technology being enabling healthcare last 15 months. In fact, the first guidelines to enable making teleconsultation legal came on 24th March of 2020 in the midst of pandemic last year. So this is something for hospitals to ponder over. I've been in healthcare for the last 6 years now, more as an administrator, being CFO for large hospital networks. Now, of course, I'm in M-Fine, a tech startup. So outpatient department as a vertical in a hospital has just been seen as a funnel in the organization, just to see how my inpatient or my wards are filled up with patients and how I can do acute care. Hospitals are by design built for acute care management. And is preventive care and NCD care core to hospitals? Maybe the answer is no, because they are not designed for that. Can technology enable to scale this verticals and patient engagement with hospitals? The answer is, of course, yes. And the solution could be use of technology with the existing infrastructure, and we create a hybrid model, because that's something which we need to do. We have amazing infrastructure to take care of acute care, but we have not been using technology. I'll just give a small example. During this second wave of COVID, we treated nearly 45,000 patients using remote consultation as a model, patients across the country. And 97.5% people didn't go to hospital. They got cured at home. So we were very well overwhelmed that at least those 45,000 people, many of those 45,000 people actually didn't go to hospitals. But are we ready to use technology in managing people at home? There's an interesting book which was given to me on the first day of my job in a hospital by the HR head, where it says the patient will see you now. Things are changing very dramatically in this world and in this country for sure. So this is a map. I thought I should show this map to you. These are dots. These are the dots of people who have consulted on our platform, and there's a 3-month data. So it just says that people from Kargil to Kerala, from Northeast, from Tura from Kohima to Kutch, from Kargil to Kanyakumari, people are amazingly using technology to get access to good healthcare. And if you see the northern part of India, we discussed the doctor-patient ratio. We all are, I don't want to go to the data, but we all know how doctor deficient, actual good care deficient we are in northern parts of the state, in the country. And we do see how those people, so we have 45 crore smartphones. We have known that we have access to technology, internet is available. And now these clusters show us people are ready to use technology. Now, are doctors ready to use technology? So this is some data I want to share. This is again data from my own company, just to say that how, if you see the graph, after the first wave, how doctors have started actually being part of the teleconsultation or using technology as a part of the journey. I won't say teleconsultation, it's just about anything, about providing care remotely using telephones from anywhere to patient anywhere. This is just to show that. And this is how we could build footprint using technology as a medium for labs, radiologists, hospitals, doctors. And in fact, very interesting thing happened recently. We have a care team, triaging team at hospital, and last 1 year, we are not working from offices, we work remotely. So for first time, we had 2 doctors onboarded in the triaging team. One was in Srinagar and one was from Andaman Nicobar. We never thought that we would have a doctor from Nicobar Island triaging a case for a patient from Patna to consult a doctor in Kolkata, sitting in Nicobar and triaging the patient. So that is something which technology has brought in, and of providing access. We are very excited about that. This is something, while we are talking about technology, while we are talking about the access, we all talked about how data is going to help us. So this is a report from EY, which came out in September 2020. So I just picked up some things to know what's happening on that. So the major decision factors why patient would want to do a teleconsultation or use technology for consultation, and what are the decision factors. So one thing which is bothering for doctors, but what patients are expecting is availability of doctors and ratings of doctors. As a platform, we have always not liked to do ratings of doctors on our platform, but there is some expectation of social validation that the doctor is a good doctor in a public platform. People are looking for this. The other challenge has been in the system was whether a doctor will be available at a given point of time. 18 months of experience now, 2 years of experience here and 4 years of M5. We now find 95% of the doctors do show up on the appointed time to do a consultation on the platform. There have been concerns on control of data and so on and so forth. The other thing is, this is very interesting that 46% of the people would like to do their consultations and the follow-ups on offline digital mode, because they find nowadays, while people said hospitals are the safe havens, doctors shared here that the hospitals possibly the most safest place, but we realized that the most infected place was hospitals during the second wave. So I had a difference of opinion there. We also see that now 83% people are willing to do a teleconsultation for common ailments. They really don't want to go. They want to flip a mobile phone. And with the convenience that you can see a doctor from morning 7 a.m. to night 1 a.m. or nearly 24 hours, it has become more pervasive. The last interesting data on patient expectation, of course, is on the money side, is that 91% don't want to pay more than what they would pay for a physical visit. And this is something has been one big challenge, because many doctors believe that they should charge more because they are for hospitals or healthcare systems. I think this will evolve. So what are the concerns by doctors? Is there only one story? The other story is from the patients. Doctors are perturbed by this whole concept of ratings by patients, which is not fair because this Uberizes them. This is complicated time. The slides up there, but delayed payments. This is a random admin rant, which we can solve out. A lack of remote and diagnostic solutions, which is getting built now. Prashant is building and so many others are building around this huge amount of infrastructure. So all these concerns, while they're valid and they're solvable through policy self-regulation and also, I'm sure, some loss of information. Just to conclude, Prashant, very quickly, this is what I want to leave by saying that it's not a question if a hybrid model is here to stay or not. It's a question about how we enable the hybrid model, how we create, because we know that 70% of the patients outpatients need not come to the hospital for a consultation or follow-up. It can be done from their home. I hope with technology, we'll be making it affordable, accessible, available, and of acceptable quality, which is, of course, WHO's motto, and which is a motto which we are trying to build where I'm working today. Thank you. Over the shot in the Prashant.
Thanks for the quick and lovely presentation.
Thank you.
Yes, we will move on to Akriti, and since our first interaction, Akriti, but may I also request you for the same? I know that you will be able to do us justice, so over to you.
Yes, thank you so much. Just let me know whenever my screen is visible so that I don't. Yes.
Yes, good to go. We can see you. If you can make it full screen slide more, it will be better.
I have done that actually.
Yeah, perfect.
Yes, great. I hope I'm able to keep up with the time of Mr. Vishwanath. I hope he was quite fast. So just to give you a quick introduction, my name is Akriti and I lead the healthcare and medical devices practice at Invest India, which is the National Investment Promotion and Facilitation Agency for the Government of India. And today I will be giving a quick snapshot of the Indian healthcare ecosystem and, of course, majorly focusing on the new incentive schemes that are launched by the Government of India. I think the facts and figures on these have been very well covered by the first panelist, Mr. Pradeep. So I will not like to maybe repeat it, but just maybe quick going around the panel so that all the stats are available in one go. So this is the market, and this is the hope that we have from the market of creating 40 million jobs by 2030, and the market size of 372 billion. I think this number will definitely increase after the COVID as well. So we hope to achieve a greater number by 2022 rather than the expected number of 372 billion. So moving on to the key segments that are available within the healthcare market is, of course, the first one being the which forms the major crux of the healthcare ecosystem, is the hospital and diagnostic chain. And the next one is the medical device manufacturing, which is yet a nascent industry, but of course seeing great growth, especially owing to the COVID pandemic as well, and medical insurance. And I heard this is something that is going to be covered in later panel discussions as well. And of course, as Mr. Vishwanathan mentioned, the MFINE digital healthcare platforms are growing owing to the like the pandemic as well. And of course, I totally agree with Mr. Vishwanathan when he said that we need to enable the hybrid model. We don't have to now deliberate whether it will exist or not. It will sure will, but we need to see how best we can leverage that model. Moving on to the medical device manufacturing ecosystem in India, currently it's the 4th largest in Asia. It's around 12 billion right now, and it's expected to grow with a CAGR of 11% to 50 billion by 2025. We have 100% FDI allowed through automatic route in this sector, and this sector saw around 2.2 billion USD as on March 2021 as investments. The key segments, as you see in the green area, are consumables, disposables, diagnostic imaging, dental products, orthopedics, patient aids, and so on. So as the topic of the presentation was to understand the healthcare, the investment opportunities available in the healthcare ecosystem, I would like to quickly make the audience go through why India is a favorable and sort of the best market for investing in healthcare right now. The first point being the population. We will be around 1.45 billion by 2028, which is the largest, which will make us the world's most populous nation. So we will definitely need more healthcare infrastructure to handle our population as well. And of course, the burgeoning middle class economy, which will sort of enable the third point, which is creating, which makes us, which is more important when it comes to talking about increasing health awareness, changing lifestyles, and of course, increasing the lifestyle diseases as well. And the fourth, and not last but not the least, the point about the life expectancy, which will grow to around 70 years by 2022, which sort of highlights why we need a robust healthcare ecosystem in the future as well. The second point is, of course, the government support and incentives that will sort of promote and make sure that investors invest in this sector as well. So we have the lowest corporate tax income in the Southeast Asia, which was lowered from 30% to 17%. We have a great competitive factor cost, hassle-free lands when it comes to even setting up factories at medical device parks such as AMTZ and the Sultanpur Medical Device Park in Telangana. The next important point is the ease of doing business, which is something that the government recognizes as very important when investors are coming to invest in India. And for that, they have set up empowered group of secretaries and the project development cells, which is sort of created to make sure that investors get the right support and get the right hand-holding support during their entire investment life cycle. So this slide gives you an overview of the existing global medical device players in India right now. And the second slide gives you information about the domestic players who are actually making in India for the world. The next and the most important slide is covering the production linked incentives that have been launched by the government of India across various sectors. If you see on the left, these are the sort of the objectives of the production linked incentives that exist across the 13 sectors that the government has announced. And if you see, it's mostly to make sure that investors come to India and also use this as an export hub as well, and make sure that the import dependence reduces and we become the Atmanirbhar Bharat that our Prime Minister envisions. This on the right is a pretty busy slide, which will show you how busy the government has been in launching these schemes across the 13 sectors. Some of the sectors have already seen applications, some of the applications have closed, some of them have opened. And to move on to the sector wherein we will sort of discuss the incentives are the medical device production linked incentive scheme. The expected outlay is around 460 million USD. The investors will get 5% incentive with the incremental sales. This scheme is being implemented through a project management agency, which is called the IFCI. For the investors who are interested in investing in this scheme, the application deadline is around 28 July. It has actually reopened to cover the entire investment that the government outlay the government wanted to have for this sector, because the government sees that we need to reduce our import dependence, which is around 70 to 80% in the sector. So if you can see, this slide covers the eligibility criteria for the scheme. I will definitely share this slide. I understand these slides are a bit heavy for for people who are not aware of this scheme, and they can definitely go through the schemes. They can go through the guidelines that are available on the Department of Pharmaceuticals website. But these are the target segments. If you see on the left-hand side, these are the target segments that the government has recognized that need most investments, because we saw, especially during the pandemic times, we saw that our dependence on other countries or other areas for medical devices was very high. So this is a very timely scheme and a very timely opportunity for investors who are looking to invest in these target segments. So the next slide, I will just cover a bit on the applications that have already been received in the sector. As you can see, 14 applications have been approved out of 28. And on the left, you see the approved applicants. And on the right, you see the segments within which these applications were filed. Now, moving on to the PLI 2.0, after the success of PLI 1.0, the government definitely saw there were a couple of target segments that were missed out in the previous scheme. So the government envisaged introducing a PLI 2.0, which definitely covers the in vitro diagnostic devices, which is, of course, a very crucial segment in the medical device sector. And especially if you see in the COVID times, the testing kits, the rapid diagnostic kits, those were the ones that actually saw a lot of uptake in the market as well. So for that reason, the government launched this scheme. The application deadline for the scheme is 31st July. And the criteria of incentive allocation is basis the global manufacturing revenue that you see is split across group A, B, and C. So last but not the least, Invest India is your one-stop shop for any query or any suggestion or any market report that you need, and we will help you across. We will provide end-to-end facilitation, whether it begins with the pre-investment stage where we help you understand the opportunity. We sensitize you towards the opportunity. We help you understand the cost-benefit analysis of setting up your project here vis-a-vis other countries. We help you understand the policies, and if there are any regulatory challenges or hurdles that you face, we help you. We help catalyze those steps for you as well. The second block, if you see, is the investment execution on ground. We help you with the regulatory clearances. We help you understand which site would be the best for which product. Like, for example, we have a cluster of medical devices, and of course the pharmaceuticals. We have different clusters across the pan India, and we help you understand which product or which entity which you should actually set up in which area to utilize the existing supply chain as well. And the third one, which we consider the most important, is the issue resolution and the policy advocacy, so that our engagement with you is through and through, and we help you understand. We help you even if you are facing any challenges in the existing project, as well as if you're trying to expand your project as well. So the main goal is to provide you comprehensive facilitation and also ensure ease of doing business. So this is the last slide that I have, and this covers our email address. I will definitely maybe share the email address and our contact with the organizers, so that if there are any queries or if you have any issues that you want to discuss with us, you can definitely reach out to us for that. And with that, I would close my slide. Usually I take around 10 to 15 minutes. I hope, Prashant, I will help you speed up the panel discussion.
You were a great help, and I had no reason to butt in. Thanks a lot for helping me out there. So thanks for sharing your contacts also, because I'm sure a lot of people will want to reach out to you. If there are any question answers, you can send it on the question answer or the chat for the attendees, and we will raise it and we will address it when the time comes. Next, we would, Professor Palucci has not been able to join in because it's already midnight at Sydney where he's based. So we will move on to our last speaker, Mr. Neeraj Kulshrestha. Please go ahead, sir.
1 minute. So good evening, everyone. I think first of all, I just want to thank ICC for providing us this opportunity. Being the last speaker, I would not bring about my presentation, although we are also used to providing presentations. So, and I also won't take a lot of time. See, broadly, what I would like to quickly talk about is this sector. We have seen the dynamism of the sector. We've also seen the kind of huge efforts that are there, particularly recent COVID times have certainly shown at least one thing, that if there were employment in any sector, it was there in this sector. Okay. I mean, other sectors did face some pain. And of course, I mean, having said that, I mean, that's probably more from a financial perspective. I'm sure every sector has had its own challenges. And we also know what's happened in the medical sector. What I try to talk about is that capital markets are an important source of funding. And just a few brief facts. One is that this sector is undergoing a lot of dynamism, primarily because there is one set of the old school, which is hospitals, the standard ones. Then there is a new technology related businesses, etc., etc. So there is a vast variety of, I mean, medical equipment. I mean, I'm not naming everything. I mean, you are all experts. So I would just talk about it. So what we talk about is how capital markets can be used efficiently for the purpose of funding a lot of the growth, because there will certainly be growth, and whatever capital markets are one of the means in this regard, and we provide platforms for various kind of organizations. I mean, there are the large companies. So I was just doing a rough assessment as to how many medical companies are listed on the exchange. So the number is around between 70 to 80, some huge number, which covers the wide gamut, which covers, you know, the large hospitals, Fortis, etc., all those. Plus, it also covers different kind of pharma developers, including, of course, quite a few international companies who have their Indian arm, companies like Biocon and Pfizer, etc. And then hospitals like Narayan Hrudayalaya, etc., etc. So it's a very, and you know, Path Labs, almost everyone has come. And I can tell you there is, from an investor perspective, there is a lot of appetite. However, there is a maturity which is required to come to the capital markets. By maturity, what I mean is that, you know, when everyone needs capital. So in the sense, there is a competition between different sectors. But here in the capital markets, which is through the stock exchanges, what you are doing is you are going to the common man and asking him to invest. There is an opportunity for everyone. I can tell you there are, I mean, we have seen small hospitals also come and get listed. And we have different platforms. For example, for the small hospitals, there is the startup segment. You know, for the small biotech, new technology related firms, you have the biotech startup segment. Then we have the SME segment, which is small and medium enterprises. We have, and it caters to small hospitals. And then we have, of course, the larger one. Essentially, capital markets are about when you have to go to the public, there has to be some kind of a track record so that people know you. And I'm just talking very, very basic here because I understand that probably this is not this thing, but, and the track record means, you know, there should be some amount of story and facts which can be brought about to the small investor so that he gets convinced and then he's ready to invest. And then, so while this is the different kind of segment, then there are different kind of instruments. So I'll just give you a simple example. We have, some hospitals have discussed this in terms of funding through bond markets, for example. So all hospitals get cash flows because, I mean, you have so many patients coming in, you get cash flows. So based on that, you keep getting money every month. Now, how can, if you issue bonds, which require you to pay interest at regular intervals, this is one of the means, the inflows which are coming on a, let's say, monthly basis, how they can be monetized, etc. So there are financial experts sitting there who can help create models which can help fundraising. Because as a fund-starved country, there are very limited choices for most of the entrepreneurs and most of the professional organizations, let's say hospitals or companies, etc., which are into this medical sector. The typical requirement is always met either from their own funds, which may or may not be endless, or through let's say bank finance or family and friends, etc. This has been the traditional way. There is a new segment which has come in, which is like, you know, private equity and that kind of funding, which is private funding, is what we call it. And that's that. I mean, but they come with their own attached preferences and requirements, etc., etc. So it has its own nuances. And then finally coming to capital markets and the broad, again, what, you know, people fear that, okay, going to stock market, what is it? Will it be very tough, etc., etc. So as I said, the second thing people feel is that when I list a company on the stock exchange, I will be losing control of my company. So, you know, since the time is brief, I would not elaborate too much, but all that I tell you is that, let's say you have a 100% company. I mean, you are today the 100% owner of a hospital or a medical company or whatever. And you are able to, I mean, whatever you are earning is based on or whatever you have to deploy is all your own funds. Now, if you have to give 25% of that to some investors through the stock exchange framework, you still own 75% of the company. And based on that 75%, the reason why people come to stock markets is for a very basic concept called valuation, because that's where you get value. So you may feel that, you know, a person who is running a company essentially may or may not, I mean, you are doing all the hard work. There is no doubt about the hard work, entrepreneurial spirit, etc., etc. But the value that you get out of stock markets essentially overcomes that 25% that you give out. The returns from capital market, and if you see how the prices rise, etc., of course, I mean, they fall also. It's all based on performance. But the valuation that you get essentially helps you in a lot of ways. Because a lot of, so for example, in my SME segment, some hospital had come, they got listed. I forget the name. It's some hospital, I forget the name. It's from Goa. Now, once you get listed, your information is there out in the public. Banks are ready to provide you easier finance terms, etc. You can pledge the shares and get money from banks based on better terms, etc. So there are so many benefits which come about from capital markets, and it's an area which should be explored. And of course, we are always there to help you in a bit of it. Of course, we are on the other side, to be fair, because you list with us. So while we will be supportive on one side for your listing, we will also be equally tough with respect to ensuring that you need to provide your quarterly results or 6 monthly results, depending on if you're a large company. Because finally, stock markets are about 2 or 3 things. One is, while they give you the valuation, they are about information. And as long as information is provided, it gets priced into the shares that get traded on the exchange. And the promoter gets value out of that. In the interest of time, I would just end here. Thank you once again for providing us this opportunity, and I think it has been a wonderful session listening to everyone here. Thank you.
I wish I had 2 hours for this panel, because each of you is a gem of a speaker, and I wish we could do a workshop with each of you. Probably Mr. Kulshreshta's topic is so interesting and enticing. So is Akriti's. Bishi said some very good points. Mr. Pradeep, our first speaker, I found his points also to be so interesting. But thanks a lot, panelists, for cooperating with me and for trying to make up for lost time, because we have one more session left and Dr. Ashwini is going to handle that. and I want to pass over the baton in a better position to her. So thanks once again, all of you, for being such a lovely part of this panel and for providing such lovely information. And now over to you, Dr. Agriti, for the plenary 3. It's all yours.
Thank you.
Thank you.
Thank you, sir. Thank you to all the panelists for a very engaging session. We now move on to our last session, last panel session, that is on healthcare insurance, medical devices sector of India. And I would like to invite Dr. Ashwini Jogare, member ICC National Healthcare Committee, MS Nanavati Max Super Specialty Hospital, and Mr. Abhijit Chatterjee, ED and Head, Claims and Customer Services, IFCO, Tokyo General Insurance Company Limited.
Thank you.
Mr. Sanjay Datta, Chief Underwriting, Reinsurance and Claims, ICICI Lombard General Insurance Company Limited. Mr. Rajiv Nath, Forum Coordinator, IMED, and Mr. Abhishek Kalra, Associate Vice President, 3D Technologies, Alton Technologies Private Limited. I would like to now request Dr. Ashwini Jogare to please proceed with the discussion. Over to you, Mr. Jogare.
Thank you. Can I know what's the time? When should we wind? It's 7:54 now.
It's 7:54, and we have how much time, Shubhajit?
I think 45 minutes.
Okay, 40 minutes.
Yes.
This was indeed a lightning session because we had a great talk on healthcare investment and opportunities. It's indeed everyone's favorite topic. And from the stock market, now we come to insurance. So it's a good jump because insurance is the one sector which is going to help all the society. And all the esteemed panelists already introduction has been given. Without taking much time, I would now straight away bang on to the questions. To Mr. Abhijit Chatterjee. Hello, sir.
Thank you, Dr. Ashwini, and thank you, ICC, for giving me an opportunity to share the platform, to share the forum with all of you. Yes, Dr. Ashwini.
Sir, even when my own parents were admitted, my brother was always worried that, will we be able to bear the cost? He being into an IT industry, so if this is a status in my home, I wonder it will be in at everyone's place. So the big question is, has healthcare insurance really percolated down into the society? And what are the market trends you see over, I think, last 5-7 years, insurance awareness has increased and people have been taking healthcare insurance. So what is your analysis of market trends and future, sir?
Yeah, thank you, Dr. Ashwini. Yes, it's a fact, good observation on your part. It's a fact that health insurance has come up in the last 5 years in a much faster manner. Prior to that, to be very honest, the penetration of health insurance in India was less than 1% or so. But with government also taking initiative, with awareness of the people also going up, that penetration, I won't say that it's really increasing, but the number of people taking insurance, health insurance, is moving up. But still, a lot is to be desired. A lot is desired from the insuring public because it doesn't come naturally. The insurance doesn't come naturally to anyone. What we've seen in the last 4-5 years is that even government, the government of India and the state governments, they also have promoted a lot of government schemes for mandatory insurance through Ayushman Bharat. I mean, that allows a lot of people who are there below the poverty line to be compulsorily and voluntarily insured for a smaller amounts, but still the cover is available. But so far as the middle class and the other strata of the society is concerned, the insurance penetration is still a lot is to be desired. Persons in the younger age bracket, they are still not taking the insurance unless they are covered by their own employers. what we have really seen is that with the onset of COVID in the last 1 year or so, that realization that the hospital expenses are huge and you really need a protection, that has compulsorily forced them to think in terms of the insurance. And this is what I would say, that when they have realized that without the insurance, it will be difficult to have the expenses covered. The expenses are becoming huge. I mean, especially if you go to a class 1 city, especially if you go to a metro, the expenses incurred in a hospitalization is a lot high, and it needs to be. It's not possible that one person is able to protect himself only on the basis of his salary or other income, and insurance becomes a need of the hour. And I would say that the COVID has really made the people realize that the insurance is really required to be taken, and that need has really come up. Hopefully, this would really take the matter further. Right now, we are observing that most of the corporates are taking care of the insurance of their employees, but those they are also taking care of the employees only to a particular sum insured. I mean, that sum insured usually is in the region of about 2 and 3 lakhs. But nowadays, if a person gets hospitalized, the expenses at times, I mean, a few number of times, they go much beyond that. And that is when the need for the individual health policies, they come into the picture. I mean, everyone needs to be having an individual health policy. They also need to be having a kind of a sum insured, which is adequate to take care of the protection. I mean, that fixing of the sum insured also becomes a major issue. I mean, for better, I mean, more expensive is the city, one needs to be taking a higher sum insured, especially the metros. I mean, definitely one can think of a sum insured band of say 7 lakhs for a metro or a 5 lakhs for a class B city, things like that. This is what we really feel. And so far as the insurers are concerned, they have taken long steps, in the sense that most of the insurance companies, they have a tie-up with the major hospitals, with a good number of hospitals in most of the cities. As a result of that, we are able to provide the cashless service. And that incentive is definitely there for the insuring public to look for the insurance. If someone is not able to get admitted in a network hospital, then they do have the option of getting treated at the hospital wherever they are looking forward to, and then submit the matter to the insurance company for a claim under the policy. This is, in short, what I would like to share so far as the health insurance is concerned at the moment.
Yeah, quite insightful, sir. You correctly mentioned the policy, the premium amount should be correctly done, especially in a metro city and tier 2. Because we have seen the trends when patients are very happy as insurance is there, but hardly 2 or 3 lakhs. That definitely won't suffice. You know, in today's era,
yes,
the insurance amount, some insured should be definitely of a significant amount depending on the sector. And thanks to bringing out the point of government insurance, I have personally witnessed it's really beneficial. Government insurance schemes, the poor family, they definitely can help. The small children, they can avail the facilities of congenital cardiac surgeries, onco treatments, thalassemia treatment, surgical treatment. Definitely a great beneficial in government health sector, schemes also. So thanks to bring out that arena also, which I mean, definitely our August audience would love to hear that. So now we move on to Mr. Sanjay Datta ji. So again, your views, like people are confused whether it's a corporate, whether it's a TPA, whether it's a cashless. In case if you wish to enlighten us about this also, and your experience, how far has the insurance, healthcare insurance percolated into the society, and what do you see the future in this?
First and foremost, thank you, Dr. and ICC for hosting this forum. I'm happy to be part of this discussion, and one of the key parts which I would like to take further from the earlier speaker, Mr. Chatterjee has started, is the fact that there is a huge shift now taking place in terms of the role of insurers, or you could put it as part of the whole, who pays for healthcare, access to healthcare treatment, and the whole evolution of how healthcare treatment will be availed in future. The role of financial access to healthcare treatment is also undergoing a big change along with healthcare. Some of the key parts I think has been highlighted, but the most important part is the requirement for both the sectors to now work together for the making sure that the customer, which is our customer, and the healthcare customer, who are the common customers, avail of the access to the healthcare at specific time wherever they need it, in a manner which is both affordable and sustainable. I'm using these words very strongly. Affordable, for the customer, and sustainable for for the payers, in the sense the ones who pay for and on behalf of the customer. So if he's, let's say, not without any help, which I think got highlighted, let's see that he's and about 60% of India's treatment is out of pocket. Imagine the burden on that person if he's paying out of the pocket. Our goal should be for universal access to healthcare, which is done through a payer which is not coming from your own pocket. So either you avail a government scheme, or you have access to corporate schemes, or you are buying voluntary health insurance. And finally, there you have access to certain amounts of financial resources which allow you to access healthcare at critical times in your life. And this particular recognition has been very starkly made during the pandemic, and that's where so it's very, very clear that access to healthcare in a country like India, which cannot only be given by the government thing. Immediately, it started with government providing help, starting even with testing. It got it got the private sector was included in the whole effort to test and treat the people who had who experienced pandemic. One of the key things there was the whole issue of what kind of treatment takes place. So a lot of new changes came in terms of the treatment protocols, which got defined by ICMR and various other bodies, and also at state level, a lot of regulation came in terms of what kind of costs would be possible. This came out of a need because of the lack of access to system which is able to provide money for for accessing private healthcare. And that's where the whole it came out very strongly. Why did we need to have this, where you needed to specify rates which need to be capped or whatever it is? If there was access, there would be no need to do that. So that was very strongly evident, because a lot of people were uninsured in India or didn't have any access to any kind of inclusion. So that's where I think the government had to step in and control the rates both for testing as well as treatment. So the other part, and which is very, very important, is the whole issue of linked to penetration. And this here, I would like to explain two things. Penetration, affordability, and sustainability of insurance all go together. And if we do not penetrate, I think the earlier speaker talked about 1%, and now I think it's moving, in terms of voluntary health, some form or the other, covering 10 to 11%, and then if you move forward, some other schemes together, more and more, people are getting covered in some form or the other, albeit, at levels which may be inadequate for very critical treatments, but still, coverage has started in India, and for that to happen, we need to make sure that the 1.3 billion population, have forms of coverage which are like they happen outside some of the developed countries, which are cradle to grave kind of coverage, which basically means that they have coverage at all periods of not only when they're employed, in retirement they don't have coverage, or very early on when they're born, some of them don't have coverage. So that's something. So there is talk of universal, insurance, and I think some form or the other the government has started that. That's a very good initiative. The second part is, of course, the role of voluntary, insurance, health insurance, which is picking up. Awareness has gone up very strongly. I think the industry has been very, very quick to react. Even in the midst of pandemic, regulators encouraged us to be able to come out with single risk policy for the first time for infectious disease for corona, which was the first, anywhere in the world, because no one gives cover for such a risk during a pandemic. Actually, so that's something which came up. Arogya Sanjeevi, cover called Arogya Sanjeevi was started with the help of the regulator, which covers, population at a standard cover, which is which was done across all the companies in India. So these were starts which were very, very encouraging. Just to bridge the protection gap, just to be able to make sure that more and more people are brought under the insurance.
It was quite helpful, sir, for our insights. In your vast experience, what is the significant change you have seen over years? One tagline or one small takeaway for us?
One of the, I think the most, one is the whole role of technology, which is becoming more and more pervasive. Not only technology in terms of healthcare delivery, not only technology, using the technology in the preventive aspects of healthcare, be technology in terms of bridging the gap between parent providers. A lot of things are becoming digital. And last but not the least, the NDHM initiative, which is, I think, started last year, in the initiative where the entire there is a digital architecture for making sure that starting for electronic health records, digitalization of hospital records which the payer is able to access. So, and various regulatory bodies slowly coming together. NHA, the NHAI, the NABH, and the other regulatory bodies, even IIDA coming together as a quasi regulatory bridge, which fosters innovation, make sure that healthcare transforms and becomes affordable, and finally even the insurance sector also are able to develop covers and benefits both on every spectrum. We were normally a hospitalization driven kind of coverage to covering outpatients, and finally being able to cover home, give home cover. Last but not the be able to also incentivize a lot of preventive initiatives through the insurance process itself.
Thank you, sir. So now we move on to Mr. Rajiv Nath. Sir is a forum coordinator, AIMED. So we as doctors, and when we want to have our own setups, somehow we want to be entrepreneurs, or if we are in a corporate hospital, or we are in a small diagnostic center, or we want to manage some of the other nursing homes, smaller hospitals. The toughest task and the biggest challenge we face is the cost of the medical equipment. And of late, technology has kept on evolving, and every 2 years technology is outdated. Again, we have to invest something in medical technology. Devices are very costly. So what is your judgment about this, and how do you want to enlighten us, all the audience, that how can we tackle this?
Thank you, Dr. Ashwini. Well, I would say that yes, this is a problem that we have to get out from. And like doctors give better medicines to patients, it's something you have to give to yourself for some time. So there will be some pain, and that pain is that Last year, the imports went up again to, every year they go up. Last year, they went up to 45,000 crore rupees. India is 85 to 90% import dependent. And we will keep on being so much. And the medical community, like yourself, is then exposed to imports and the increasing devaluation of the rupee against the dollar. So every shipment and every 6 months, the prices will keep on going up. So you have seen that in products like syringes, for which India is Atmanirbhar, where we make our own medical devices for many years, there's ample competition in the country, and the prices do remain stable, they become competitive and they go down. So we do need to swallow the bitter pill of allowing the custom duties to go up to 15%. Currently, they are either at 0% or 7.5% maximum. The government does realize, Niti Aayog and TOP, that India has a product disability factor of 15% in terms of global competitiveness for manufacturing medical devices. So most countries do give that much kind of custom duty protection. WTO permits up till 40%. But because the medical community is so strong, your lobby is much stronger than us manufacturers' lobby. So you keep on asking for lower duties to be affordable. And you keep on doing that, but then you will always be import dependent. So it's a chicken and egg story. So we request you for some time, trust us, allow us to manufacture the product. When we make the products in the country, and you've seen that in the last COVID times, what has been the big change now. So in the last COVID 1.5 year, 2 years time, you've seen that whether it was masks or PPE coveralls or ventilators, many manufacturers in auto components, in furniture making, they've stepped forward and diversified into making the products as a national cause. They've subsidized the investments to certain levels. But yes, we've shown by the entrepreneurial spirit that we can make the products. So technologies can be absorbed, products can be made, but for some time we do need a support. And what we've seen in COVID times, that support needs to be carried forward by the government and by the medical community. And by doing that, we'll be one day be having sufficient capacity and adequate competition, and that competition will keep down the prices for you. So bear with us. Thank you.
So you agree that Make in India is the solution for this?
Yes. So of course, one cannot make everything. There will always be some imports. But yes, what can be made should be made. I mean, look at your own hospital. If you will walk around and go to your stores, you'll find that nearly 70 to 80% of the consumables and the implants that you use are coming in. And why can't we make them? A simple thing like a spinal needle that you use for epidural for a baby's delivery is going to be imported. The IV cannula that you use is made in the country. We are one of the biggest exporters. And that is another challenge, that the doctors will prefer to use the imported brand and not the Indian brand. So that's the second challenge. The second challenge that we face is that the doctors do need to support us in one more area. In the nursing homes and in the doctor-owned hospitals, we have that support, but not in the corporate hospitals. And that is, for the last 10 years, there's been a big shift that the hospitals are managed by the professionals who are from the finance background. They're looking at the stakeholders and the shareholders' responsibilities first, the profitable bottom line. So they are wanting to use products with a higher MRP and a higher trade margin. And when you're going to look at Indian products with a lower price, when we're trying to be competitive, we're coming with it to you with a lower price. And of course, with a lower MRP to be more consumer friendly, we find that we become non-competitive and non-attractive. Because the purchase manager will tell us that if I use your syringe, I lose 5 rupees from every dispo man. If I will use the BD syringe, I can use another 5 rupees on the BD syringe, which is a 10 rupees I can charge the patient, unlike a dispo man for 5 rupees. So we have a position where we try to be affordable, but we lose out on the area where the hospital will buy the product, because they're looking at the trade margin to cross-subsidize the other products in the hospital. So that is something, again, a trust factor has to be seen over there, where we need to have a balancing role, that the patient needs to be charged on the real costs and not on cross subsidies. Thank you.
Thank you, sir. So now we move on to Mr. Abhishek Kalra, LTM Technologies. So we are in now an era of everything 4G, 5G. Similarly, we have now era of 3D technologies interfere in helping the surgeons, helping the clinicians, helping the radiologists everywhere. So your views on, I think you have a small presentation. If the administrator can allow him screen sharing, we would like to see the wonderful presentation of how healthcare outcomes can be improved using 3D technologies. All over to you, sir.
Right. Thank you so much for inviting me to this wonderful forum. I was very impressed to see some of the hear some of the speakers. Now, my topic is going to be a little bit of different, but it covers the fundamental problems that many of the speakers have addressed in their area, including the last gentleman who spoke about uh, uh, localized medical device manufacturing. Right. So I'm Abhishek. I represent a company called Altum Technologies. Long story short, we are a 3D technologies company, and we cater to a lot of industries, from automotive to aerospace to medical devices to dental, so on and so forth. And at the core of it, all these industries have similar problems. The problem is to create the best possible product or process outcome in the lowest possible cost in the lowest possible time. So that's the kind of problems that we solve. Now, what is the need of 3D technology integration in healthcare? India and has some of the oldest established patient care practices, right from our Ayurvedas in the pre-modern medicine times. But today, with the COVID and generally beyond, before COVID also, we see that a lot of patients suffer. They suffer because both it's difficult to get access to treatment, but more importantly, it's difficult to get better access to good and high quality treatment. So there are two broad challenges that I have seen in my experience. First is the availability of from a quantity perspective. If you look at the Apollos and the Max, they have all the state of the art technology to be able to diagnose and treat any disease as quickly and as efficiently as possible. But if you look at the primary health centers in the rural areas, you and I both know that they are in very bad shape. And the second is, does every doctor and every surgeon in the country have the capability to solve the most complex challenges without increasing both the risk as well as the cost to the patient? And that's where 3D technologies and technology integration comes. So we need to solve some of the challenges in the country that allow good healthcare access to come to everybody at the best possible cost. Now, in manufacturing, which is one of the backbones of the country's economy, is any product that is manufactured, from a pen to aircraft, is actually tested before they even start production. So there are digital and 3D techniques available in manufacturing that allow you to test a complete aircraft, that how this aircraft will perform for the next 15 to 20 years without even manufacturing it. Can we bring a similar equation to the healthcare system? So the answer is yes. So virtual surgeries, digital surgical planning is something that is not new, but not a lot of people have been able to adopt it. And the core game changer has been 3D printing, where you kind of get access to the real anatomy of the patient before even cutting open the patient. So surgery before getting into the surgery, it's like having the access to the question paper with the answer sheet before getting into the final exam. Not only can you create like an organ that looks like a dummy, but you can create anatomies which not only look like the real anatomy, but also feel and behave like the real anatomy. You can use the same or similar tools that you use in the real OT environment to perform your practice surgeries or training surgeries in the case of students in medical colleges, and go better prepared. And of course, if you're better prepared for any scenario, you come out with a better outcome. So the better outcome could be reduction in surgery time. We have seen up to 70 to 80% reduction in surgery time. Clinical outcomes like lower blood loss, lower anesthesia, lower post-operation risks, or eliminating the need of multiple surgeries, so on and so forth. and this can be applied to any area. It could be, but obviously the bigger beneficiaries are the more complex surgeries like pediatric or cardiovascular or neurosurgeries, so on and so forth. But long story short, any type of surgery can be replicated. These are some examples on the screen, uh, uh, from orthopedics to urology to cardiovascular, so on and so forth. So the point being that this is not just a theoretical solution or solution that is being implemented in the West. At any given point of time or at any given year, there are thousands of surgeries from small domestic hospitals to larger ones like the Fortis and the Apollo who are using this technology. But of course, today this technology is a little bit expensive, and hence one speaker was addressing about the AMTS TZ set up by the government of India, where these machines exist, where surgeons and hospitals who do not wish to buy their own 3D printing equipment can go get parts done. So there's cheaper ways to get it done. Now, it could cost you as low as 1,000 rupee to maybe 20,000, 15,000 rupees. But for a complex cardiovascular surgery, where the total bill to the patient is going to be in the lakhs, it doesn't matter. We can also reduce the number of surgeries, and this is a good example where we used 3D scanning and virtual surgical planning for a cleft lip surgery, where the number of surgeries was reduced from 4 surgeries planned to 2 surgeries because everything was planned digitally, right? So for an 11-month baby, that and the cost implications of that for a poor person is huge, right? So the outcomes are very, very high. And the last point which I'd like to address is personalized care, right? Whether it be in the area of patient-specific implants, which are much, much better than the standard ones, where you can take a scan of the patient and within hours, 3 hours, 4 hours, get an implant that is designed to his or her specific problem, or rehabilitative devices such as orthopedics, prosthetics, and orthotics, which has all the impact. So you reduce the time of treatment, you reduce the cost of treatment. I was speaking to one of the national rehabilitation device account of the government of India in Tamil Nadu yesterday, where they were saying that the patient, we are ready to give the treatment for free, but the patient does not have enough money to even travel to Chennai or stay in Chennai for 1 week while we devise the treatment in the case of prosthetics. So with these kind of solutions, you can go from diagnostic to solution in hours, which is revolutionary. And of course, a lot of medical devices in India are imported, which is what the context of the last speaker was. And a lot of these technologies can be used to, again, quickly and cost effectively develop medical devices in India. A lot of companies are doing it, and the government's incentives are working very nicely for it. But I'll give you one good example, and then I'm going to end this session. In the times of COVID, we are not even able to go to a doctor, and we are sitting in urban cities, right? So imagine people in the extreme rural areas who can't go to doctors, but there are not even specialists available in those areas. So one of our customers has developed an attachment which gets attached to a standard stethoscope, where the reading of the stethoscope can be recorded and over WhatsApp sent to a specialist in the big hospitals such as the Maxes or the Fortis, and immediately an answer can be given that is it a general problem or does this person require immediate hospitalization or not. So the idea is to use technology to stitch everything together, improve the quality of healthcare, but also improve the quantity and reduce the cost of healthcare. And that's the end of it. I tried to be as fast as possible. If there are any questions from the moderator or the rest of the group, I'm happy to answer.
It was lovely. Nice to see the reconstruction, and definitely it will help the surgeons. Thank you. So quick, as we are nearing the end of the session, Mr. Abhijit, would you like to use this platform of ICC to convey the audience anything or some takeaway message? So you'll have to unmute yourself, please.
Yeah, sorry. Thank you. A very appropriate forum to convey ideas relating to medical field, healthcare, insurance, and all these things, they move together. And in fact, we are reaching kind of a stage where a lot of collaboration is increasing between the various components of the healthcare sector, like the doctors, like the hospitals, like the insurance companies, and the manufacturers of the equipments which are being used in the hospital. And this collaboration will definitely pave the way for a common man who is desirous of getting a good medical attention, which is available. I mean, India is known to have a good medical service. We are getting patients from abroad, but still, there's a lot to be done. It has to reach to the masses. It has to reach a common man. The affordability and the sustainability of the expenses incurred, these are very important. Right now, there is a scope for making these expenses, making these treatment available at the best of the advanced stage with a more reasonable cost. I think all of us, we need to be combining together to deliver and to serve the humanity in a much more efficient manner. I think this is a platform where I can request everyone to be cooperative and collaborative with each other. But thank you so much for giving us an opportunity to share our views. Thank you.
Thank you, sir. Sanjay, sir, ICC platform to convey.
Yeah, yes, I think yeah, it was a good discussion. From the key takeaway I would like to put forward is the whole issue of you know uh, you know getting people covered. It's one of the most seminal things. Now we are at an inflection in a period where everyone needs to be covered in one form or the other, so that no one spends out of pocket for technologies and treatments which are available in India. No one should be deprived of it. It's possible to do so. Just the lack of access to healthcare is a big issue, and hence I think personally, there is focus on not only on making sure that healthcare is developing, the costs are affordable and sustainable, but one of the key factors will be penetration. The larger the population is covered, and insurance, the larger the number of people who are covered, we are able to, I think, defray costs, not only distribution but also expenses, our own expenses in being able to distribute the insurance product. Hence, penetration should be the goal of everyone. But the key thing amongst that is people should start early. There has been a tendency to wait, or even during the pandemic, we found everyone, they became aware or rushed for taking cover. So hence, the fact that you will face mobility issues one time in your life, and it is important to be covered is very, very important. So coverage in one form or the other. Those who have some form of coverage would need to take what we call a top-up coverage, which makes it more affordable for you, because you have some access to some government or other scheme. But at least for critical illnesses where you may require state-of-the-art treatment in facilities which cost a lot of money, one would advise that take up covers which keep growing. As we go, there is healthcare inflation. Do not keep your covers small. Keep increasing it as you progress in life. Is one big message I would like to leave everyone. Insurers and healthcare sector is going to work together. It's let it not be your own hesitancy in not having cover. That is one key message I would like.
Thank you, sir. So, Mr. Rajiv Nath, on this ICC forum, if you would just highlight shortly about the quality of devices, regulations, etc., and anything else you want to send a message.
Sure. Yes, Dr. Ashwani, I think today's whole seminar since morning has been about costs. But cost cannot be at the cost of quality. So whether in terms of healthcare delivery or in terms of the quality of the medical device, it's very important that the patient should be getting access on quality of medical devices. Patient safety is most important for everybody. And even the reputation and the trust on the healthcare professionals is at stake if they will use something which will be harming the patient. So over here, this is something where India has been lacking. Unlike most countries, we don't have regulations for medical devices. Now we do have a rule book for medical devices, but it is still parked under the archaic Drugs Act. Devices are not medicines. They're engineering products. If something goes wrong, we have to act and treat them as engineering products like we do for cars and not like for medicines, because you cannot have absolute quality. So this is something that has to be seen by the medical community. We have been waiting for a long time for a separate act to take place. The medical community and the medical device community need to jointly lobby for a separate act, and this will ensure patient safety. And until this comes forward, the medical community needs to be considering to give importance to genuine, authentic certification. So we have the Indian certification for medical devices. Manufacturers who got ISO 13485 or ICMET certification from a certification body that has been accredited by QCI's NABCB is what you should be seeking when you're buying a medical device. You should not be considering fake certificates from CE or US FDA or ISO 13485 which are in the marketplace if they don't carry a QCI logo or an IF logo. These are the P's. So Akriti already has mentioned to you about the public procurement and the PLI to make in India. So making in India, P for protection of custom duty I mentioned just earlier, and P for patient safety is what is, I think, critical. These are the 4 P's we need to be going forward, and we seek as a pleas from you that medical community will help the medical device community come forward with this. So help us to help you. Thank you.
Thank you, sir. Mr. Abhishek Kalra, a quick.
Yes, I'd like to just say one thing, that nobody should lose their life or be refused treatment because somebody was not able to solve a complex problem. So I think the entire healthcare community, including ourselves as medical device or medical equipment suppliers, should work towards making India a country where complex healthcare problems can be solved, but not at the cost of giving a big bill to the patient. That's it. That's what I'd like to say.
Thank you, the esteemed panelists. I think we covered very well in time. We are in time. Thank you, ICC platform. Thank you, Subhajit, personally for taking all the efforts for making such a wonderful panel discussion. In fact, the entire evening was very enlightening. So with this short thank you note with a vote of thanks, I would now like to conclude our panel. Thank you. See you again. Stay safe, stay connected. Thank you.
Thank you.
Thank you.
Thank you.
Thank you, ma'am.
Thank you.
Now I would request Dr. Richa Singh, madam, to kindly deliver the closing remarks. Over to you, ma'am.
Yes, absolutely. I think after a long day, everyone is in a hurry to leave and probably head home. So what I would like to say is that in short 4 hours, I think there's a lot that we have covered, and there's a lot that has been taken up, which can actually help us prepare for the next conference. So I think in the short span and during this 3 panel discussion and inaugural session, we have covered so much that each of this topic actually can be used in future for a complete workshop, right? So that's something which I would request ICC to take note of. And a second thing which I would like to appreciate is the hard work that has gone behind all this work in terms of getting such wonderful speakers. You know, each of the person who have spoken today is the subject matter expert in their respective area, and I'm personally quite impressed hearing all the panelists and all the speakers. So kudos to you, the team there at ICC. And also with the quick shift that you have done, while we wanted this program to be a hybrid program in terms of having a physical as well as a virtual conference being put together, But I do appreciate that we are continuing to focus on more on the how to avoid COVID rather than just kind of going ahead with what we have decided. Today, the time is about flexibility, that how soon we can kind of, change gear and move into what is more appropriate at that given point in time. So it was virtually decided yesterday that we would have a virtual rather than having a hybrid model. So all of that is much, much appreciated. And thank you so much. Thanks to ICC team, thanks to all the panelists. And of course, not to miss out all the participants who have been very, very enthusiastic, right? I regret that we could not have a separate question answer session after every panel. Next time, we would definitely keep that in mind. But in the meantime, I see that there are a lot of telephone numbers which have been exchanged, or personally, you could write to ICC if there is any question, or if you would like to get connected to any particular person, and we would be happy to do that. With that, thanks once again to everyone, and we look forward to seeing you all once again soon, sometime in future.
Thank you, everyone, on behalf of ICC. Thank you.